Probably this is where we left last week, right? So as far as the energetic is concerned, of PC cycle, it is oxidation of one acetyl coenzyme produces 12 molecules of ATP. Fine. Now oxidation of one molecule of glucose give rise to 2 molecules of acetyl coenzyme. So oxidation of one molecule of glucose will give 24, 12 into 2, 24 molecules of ATP. Now prior to this pathway, glucose has undergone 2 other pathways, steps of oxidation. One is through glycolysis, another through oxidation of pyruvate. Right? So in each step, if we calculate that glycolysis will produce how many? 8. Aerobic glycolysis will produce 8 molecules of ATP, and this will produce, oxidation of pyruvate will produce 6 molecules of ATP, 2 molecules of NADH plus H plus, which will give rise to 6 molecules of ATP. So altogether it comes around 38. Am I right? This is the overall calculation of number of ATPs, correct? But if I ask you, is it truly correct? Answer is no. The number depends on tissue where the oxidation is taking place. First point. Next is, say for example, anaerobic glycolysis will produce 2 molecules of ATP, fine. But in erythrocyte, mature erythrocyte, all the molecules will not participate in glycolysis. Only 30% of it on an average will participate in formation of, in pathway of glycolysis. Only 30%. Correct? Similarly, all these steps, glyceraldehyde 3-phosphate dehydrogenase, pyruvate dehydrogenase, and all other dehydrogenases, there is a difference. Pyruvate dehydrogenase takes place within mitochondria, but not glyceraldehyde 3-phosphate dehydrogenase. So the NADH produced by glyceraldehyde 3-phosphate dehydrogenase is located in cytosol. Now oxidation of NADH takes place in mitochondria, the inner side of the inner membrane of mitochondria, right? In the badminton, what we hit with a racket, it's called shuttle. It goes from one side of the net to other side of the net. Or say, take another good example, the US space shuttle ship, which transports people, substances, material from Earth to space and vice versa. So this shuttle system, they carry this reducing equivalence. But do they carry the reducing equivalence? No. What is the function of reducing equivalent? Reducing equivalents are a specialized parts, bags, collection system, which collects and holds electron. They give away the electrons to the shuttle. The shuttle molecule will take it to inside mitochondria and give it back to either of these NADH or FADH2. So there are two shuttles. One is glyceraldehyde, one is a malate aspartate shuttle, another is glycerol 3-phosphate shuttle, two shuttle systems, malate aspartate shuttle and glycerol 3-phosphate shuttle. The malate aspartate shuttle takes up electron from one molecule of NADH and gives it back inside mitochondria to another molecule of NADH. Clear? Malate aspartate shuttle transport electron from NADH to NADH from outside to inside mitochondria. Clear? Glycerol 3-phosphate shuttle does a little bit different. It takes up electron from NADH from outside and give it back to FADH2 inside. FADH2 inside. Glycerol 3-phosphate shuttle. Okay. Now, so malate aspartate shuttle produces one molecule of NADH equivalent to one molecule of LDH from outside to inside, and glycerol 3-phosphate shuttle produces one molecule of FADH2 instead of NADH outside. Fine. Problem is, in the electron transport chain, the location of oxidation of these two molecules are different, NADH as well as FADH2. So, NADH travels through 3 transporter of hydrogen ion. The electron carried by NADH travels through 3 transporters of hydrogen ion, whereas the electrons carried by FADH2 travels only 2 ports, 2 transport system of H plus ion. Right? So, the electron traveling through NADH will produce more potential difference of H plus ion because it is passing through 3 transport system of H plus ion, and electron transported by FADH2 will transport through only 2. So, it will produce less potential difference of H plus ion across the membrane. So, first one will produce 3 ATP and second one will produce 2 ATP. Clear? Now, we don't know which NADH is going through which shuttle. Oxidation of glucose in glycolysis produces 2 molecules of NADH plus H plus. It might, I give you 3 options. There are 2 NADH plus H plus produced by oxidation of glucose in glycolysis, step number 6. So, we have 2 NADH. Now, option 1, both the NADH goes through malate aspartate shuttle, both the NADH goes through glycerol 3-phosphate shuttle, one of the NADH goes to malate shuttle, one of the NADH goes to glycerol 3-phosphate shuttle. Which one do you think to be correct? Huh? Third one. They go through both, all going through malate aspartate shuttle, all going through glycerol 3-phosphate shuttle, one going through malate aspartate shuttle and one going through glycerol 3-phosphate shuttle. Which one? Last one. Any other option? Any other answer? I did not use one word in the answer. Either. They must choose either of these. Both the shuttle cannot be used simultaneously. When you are considering two molecules of NADH produce form oxidation of glucose, you cannot consider both the mallet or mallet shuttle and Grisel shuttle to operate simultaneously. Either both of them will go through mallet shuttle or both of them will go through Grisel 3-phosphate shuttle. Clear? Either mallet or Grisel 3-phosphate shuttle. Either of these. So, if they go through mallet shuttle, then this calculation stands true. But if they go through Grisel 3-phosphate shuttle, then the calculation will change. What will happen? Instead of 8, when both NADH goes through mallet aspartate shuttle, and this is right. When both goes through Grisel 3-phosphate shuttle, then this 8 will become 6 and this will become correct. Next, after the discovery of this calculation, almost around 50 to 60 years later, they discovered that in actually this does not happen. The amount of energy required for production of one molecule of ATP from ADP and inorganic phosphate is somewhat not equivalent to the oxidation of one molecule of 1/3 of the one molecule of NADH. So, it is like one NADH will produce around approximately 2.5 ATPs. FADH2 instead of 2, it is around 1.5 and 2.5. You know, 2 and 3 bodole. So, with this the calculation again changes. With this the calculation again changes. Right? So, what will be the calculation now? If it counts for 2.5 and 1.5, first what we will do? Both the consideration we cannot take in one equation. We have to consider this one or this one. Fine? Either of these. So, let us consider this one first. So, in glycolysis it will produce 8 ATPs. So, 8 will become how much? 2 plus 6 is equal to 8, but instead of 6 now it will produce 5. So, 5 plus 2 it will be PDH. Will they do the same? Yes. So, it is 2 molecules of NADH. So, 2 into 2.5, 5. Here 1, 2, 3 means 6 NADH. 6 into 2.5 is what? 15. 1 FADH2, 2, 1.5 into 2 molecules of acetyl coenzyme. So, it will be 3, 15 plus 3, 18. What will be unchanged? Okay, so 18 plus 2 Now it is 32. Can it go further low? Can it go further low? Yes. But for the time being, we will stick to this because sometimes once they ask this question that complete oxidation of glucose produces 32 moles of ATP. Explain. Correct? Now, if it goes to mallet as per a shuttle, then this will happen. If it goes through glycerol 3,4 shuttle, then 2 less. So it will be 5, it will be 30 if it changes to glycerol 3-phosphate shuttle. Clear? You need to understand this very clearly. Once you understand it here, you will never forget. Fine? See, 32, 32. It may vary, either 30 or 32. Can it, what was my question? Can it go further low? Yes, actually yes. Actually yes. All that energy transferred in the form of potential difference is not converted to ATP. There is always a plenty of leakage in the system or seepage. The water coming from the huge overhead tank of corporation to this college has many leak points. That water will go out. Is that there? Yes, it is there. Are these leak points are good or bad? These leak points are good. These leak points are important for generation of free radicals. They are good. They provide us protection against foreign particles. But if it increases beyond certain limit, then it goes for opposite direction. When you smoke, when you take alcohol, then this production of free radicals will increase. Leakage will increase. Fine. Now, can it go further below? Yes. What I told in erythrocyte, only 30% follow, 30% molecule of glucose follow glycolytic pathway. Then where does the 70% go? Rest in HMP shunt pathway. So, is there any other tissue which does the HMP shunt pathway? Yes. All tissues perform HMP shunt pathway. So, all the glucose molecules entering into a cell will not participate in this process. Correct? Fine. So, when you calculate for glucose oxidation ATP's energy, you just don't blindly calculate how much glucose you consume and that much energy will produce. No. The production of energy is much less. Much less than we can calculate. Fine. Any questions so far? Now, if I ask you what is the role, what is the importance of tissue cycle? Significance of tissue cycle? Importance. It is the central hub of cellular metabolism. Can you repeat? Central hub of cellular metabolism. Is there anyone from New Delhi? New Delhi? You stand up. If I ask you It's a round, big round ways, roadways in Delhi. Which place you will name? Means roads surrounding the whole area. CP, Connaught Place, correct? Or you can say India Gate, it is all like that. Cars go around all the way around. So it is like a central hub of cellular metabolism. All that we eat, they converge, and all that we need to produce to our metabolism, they diverge from this pathway. Central hub, correct? If we take carbohydrate, it goes for down metabolism through tissue cycle. If we take protein, it is broken down to two parts, glucogenic part and ketogenic part. Glucogenic part goes into this machinery for production of energy. If we take lipid, the lipid oxidation produces acetyl coenzyme. Acetyl coenzyme goes into tissue cycle. Fine. And there are plenty of amino acids which we call non-essential are produced from one or other intermediates of this tissue cycle. So next question comes that the entry and exit point of different amino acids or biomolecules in TCA cycle. Because somehow I have written, I have tried to remember a few intermediates. All the intermediates I don't remember, I forgot. I don't have memory as sharp as you have. So I remember only few intermediates for this answer. What are those? Glucose, pyruvate, acetyl coenzyme, citrate, alpha glutarate, and succinylcholine coenzyme, and fumarate, and oxaloacetic acid. Clear? Have you done with this? So now I will show the exit points or entry points. Which one you will take? Entry or exit? What is the choice? Entry. Fine. What is that? Guess? Guess? And this one? Huh? Tyrosine. Why? In the first step of tryptophan catabolism, tryptophan is split into two halves. One of the portion is alanine. So they give rise to alanine. Glycine give rise to alanine. Alanine give rise to alanine. Serine give rise to alanine. Threonine give rise to alanine. Cysteine give rise to alanine. Tryptophan give rise to alanine. All alanine then goes to transamination. So you can write like this also, alanine here, and then this is by alanine transaminase is converted to pyruvate. The glucose already I have explained in the last class. From glucose 6-phosphate it can come, from diet and etc. etc. So that I am not discussing here. Now acetyl coenzyme. What are different sources? Beta oxidation of fatty acid will produce acetyl coenzyme A. Ketone bodies, ketolysis will produce acetyl coenzyme A. But see, all this will not take place simultaneously or not even in the same tissue. Oxaloacetic acid aspartate via aspartate transaminase, and this aspartate will be produced from deamination of asparagine. So entry of 1, 2, 3, 4, 5, 6, 7, 8 over. Catabolism of phenylalanine and tyrosine will give rise to fumarate. Succinyl coenzyme A. Oxidation of odd chain fatty acid will give rise to propionyl-CoA, which will be converted to succinyl-CoA. In a 3-step reaction, propionyl-CoA to dimethyl-malonyl-CoA, dimethyl-malonyl-CoA to L-methyl-malonyl-CoA, L-methyl-malonyl-CoA to succinyl coenzyme A. First one is propionyl-CoA carboxylase enzyme, which you call ATP and biotin, and second one is isomerase, and third one is, the second one is racemase, and third one is isomerase. The third one requires folic acid also. Now, propionyl-CoA to succinyl-CoA, this formation, this propionyl-CoA can also be formed valine, isoleucine and done. Glutamate to alpha ketoglutarate. What is the enzyme here? Both. Both can be used for conversion of glutamate to alpha ketoglutarate transamination. And can glutamate be produced from glutamine? Right? Glutamine to glutamine. So how many amino acids done already here? Count? Huh? 18. What is left? Which amino acids are left? I have not mentioned. Leucine and cysteine. Cysteine, which is a dimer of cysteine. Huh? Oh, lysine আছে না? Lysine actually ওটাকে বলা হয় লাইসিনে একটা স্টেপ অ্যালানিন তৈরি করে। জ্যান্থোনিক অ্যাসিড পাথওয়ে যেটা আছে লাইসিনে একটা স্টেপে জ্যান্থোনিক অ্যাসিড লাইসিনে না, লাইসিনের ব্রেকডাউন থেকে একটা অ্যালানিন তৈরি হয়, ঠিক আছে? সেই অ্যালানিনটা দ্যাট অ্যালানিন ক্যান গিভ রাইজ টু গ্লুকোজ। আচ্ছা, কিন্তু বহুদিন পর্যন্ত টিল মেনি ডেজ মেনি ইয়ার্স ইট ওয়াজ নট কনসিডার্ড অ্যাজ বোথ গ্লুকোজেনিক অ্যান্ড কিটোজেনিক, তাই না? দ্যাটস ওয়াই ইফ ইউ সি দ্য ওল্ডেন বুকস you find ketogenic amino acid 2, leucine and lysine. Later on it was changed to only leucine. Okay, so you can just add lysine here. Fine, good point to raise. Fine. Okay, if you do miss lysine also, it won't deduct any marks. Citrate is brought outside of mitochondria, then it is broken to okay. So if the question comes, explain the TC cycle is amphibolic in nature, neither catabolic nor anabolic, both. This is the answer. Describe the entry and exit points of different biomolecules, amino acid into TC cycle. This is the answer. Describe it acts as a central metabolic hub for both anabolic and catabolic pathways. Answer. One answer, many questions. But remember, all these will take place in different metabolic condition. Anabolic things will take place when you are in positive metabolic condition. Eating food, good food and taking rest. Plenty of food. But when you are starving, then the other side of the metabolism will take place. Any question? Fine. Cysteine to cysteine dimer. ভেঙে গেলে cysteine হয়ে যাবে। তারপর cysteine will follow same thing. Leucine ketogenic to. It produces acetyl coenzyme. তাই না? Regulation of P cycle. A never asked question. None of them dared to ask this question. Regulation of P cycle. It is so difficult to explain. But few points you can remember. What are those? The rate limiting steps of P cycle, the 3 irreversible steps, citrate synthase, isolated dehydrogenase, alpha glucosidase dehydrogenase. Rest all are reversible. Next, it is regulated by activity of substrate availability. Next is product inhibition, allosteric inhibition or activation by other intermediates. Examples you want? Citrate synthase. Citrate itself will inhibit formation of further citrate. Product inhibition. Correct? Citrate itself will inhibit formation of acetyl coenzyme, feedback inhibition by inhibiting PFK1. Correct? Answers you know. Only thing is you have to find out. Devote some time, that's all. Substrate availability. Which one? Oxaloacetic acid. The moment acetyl coenzyme is always there. If oxaloacetic acid is not there, then there is a pathway which can produce oxaloacetic acid. Suppose there is no aspartate to get it converted to oxaloacetic acid, then pyruvate itself will produce oxaloacetic acid and run the show. These reactions are called anapleiotic reaction or filling up reactions. I'll come to that. Wait. I'll come to that. You know? This is example of substrate availability, oxaloacetic acid. Allosteric inhibition, anywhere, any dehydrogenase step is allosterically regulated by AMP and ATP. Huh? So easy to remember. Only thing is you have to remember few points. Huh? This will be like this always. Huh? But always don't think, don't try to invent from your side. Whatever you will invent, that is wrong. At least listen from us or read from book. Do not try to invent anything. Whatever you will invent and discover, it will be wrong. 200% guarantee. Whatever you will feel like these questions, answer will be like this because of my common sense. That is wrong. Don't find common sense. It is very uncommon among the common people. What is common sense? The common sense is a sense which is very uncommon among the common people. It's very difficult. Newton had a common sense. Einstein had common sense. Stephen Hawking has common sense. A.C. Bose had common sense. APJ Abdul Kalam had common sense. Do you think you are equivalent to those? So do not try to search and waste your time for your common sense. Use your memory. With memory, sharp memory, you can, with memory power only, you can build up your common sense. Okay, fine. Now, write down what are the anapleiotic reactions or filling up reactions. Write down. Anapleiotic reactions are there. Anapleiotic reaction or filling up reaction, filling up the gaps, are reactions which fill up the vacuum produced in the TCA cycle due to withdrawal of several intermediates. কি বললাম বল দেখি একবার না পুরো সেন্টেন্সটা পড় একবার Can you repeat the whole sentence? You can't. বল গ্যাপ হয়ে গেছে ফুল সেন্টেন্সটা বল আমি কি আমি মুখস্থ করেছি নাকি কে লিখতে পেরেছে বলো ভাবিস না তোদের মতো অত ভালো মেমোরি আমার থোড়াই আমি তো মনে রাখতে পারি The anapleiotic reactions are those reactions which fill up the vacuum produced due to withdrawal of several intermediates. That's all. মানে কি সেই ইন্টারমিডিয়েটসটা অ্যানাবলিক কারণে উজ্জ্বল হতে পারে, সেই ইন্টারমিডিয়েটসটা ক্যাটাবলিক কারণে উজ্জ্বল হতে পারে, তাই ওটাকে আলাদা করার দরকার নেই, তাই না? With more knowledge your answer becomes small, তাই না? যেমন একটা ছোট বাচ্চা, এই টডলার, 2 বছর 3 বছর বয়স, তাকে যদি গরম জলে হাত চুবিয়ে দিস, কি বলবে? বাবা ও বাবা ও বাবা। আর ও বাবা ও মানে কি? হোয়াট ইজ দ্যাট? কিন্তু তুই তোকে আঙুলটা চুবিয়ে, তুই আঙুল চুবিয়ে বলে ইটস হট। তাহলে ও বাবা ও বাবা ও বাবা ওয়া 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 ভার্সেস ইটস হট, হোয়াট ইজ দ্য ডিফারেন্স? The knowledge base. With more knowledge, if you ask me, I will finish the whole question paper in half space you require. Why? Because I will use more condensed sentences to answer the question. Right? More knowledgeable you are, you can condense the system more further. The answer will be more concise. That's why it is very difficult to digest Ganong. It is very difficult to digest Harper biochemistry compared to Guyton, Weston Todd, or any other big books, Leninger, Stryer, etc., etc. in biochemistry. Because the smaller books are actually concise, they are much more condensed. Maybe one line of Ganong has been explained in 1 page of Guyton. So when you don't understand, go back to Guyton. Understand it, come back to Ganong, then make your own answer. Then your answer will be concise. But if you start with Harper, then problem will set in. You have to be very, very good in language to understand English. Before knowing the science, you have to understand English, because they concise their sentence due to efficiency in their language. So that's a difficult way. Fine. So any question from here? Then we will move on to next topic. So I will continue with next topic. Wednesday, Thursday, and Friday. Gluconeogenesis. Always after TC cycle, it is gluconeogenesis. Then glycogen metabolism. Then HMP shunt pathway. Then minor pathways. Then homeostasis of blood glucose. कोशिश करेंगे, है ना? ठीक है। अच्छा, ऑक्यूलर करो। अच्छा, now if you go through your books at your level, you will find in many books they have given one more reaction. This is isoscetate dehydrogenase. Now don't write. First you listen, then you decide whether you want to write it or not. I will not give my opinion first. First let me see your opinion. As isoscetate dehydrogenase is a cytosolic part of the form of acetyl dehydrogenase, it actually operates mostly in plants. Do you need it? Mostly in plants. Do we need it? If yes, you can write. If no, don't write. Two are sufficient. That's all.
What do you mean by platelet adhesion and platelet aggregation? এটা তো তোদের পরীক্ষাতেও আসে, এটা মনে রাখলে অনেকটা হয়ে যাবে। দুটো জিনিস মনে হচ্ছে না একই জিনিস, নাম অনুযায়ী একটু মনে রাখ। প্লেটলেট অ্যাডহেশন মিন্স প্লেটলেটের সঙ্গে platelet connected with non-platelet surface, and aggregation is platelet to platelet combination. Finish. কেন? In the previous class I discussed that platelet adhesion means whenever is the exposed collagen that causing the attachment of the von Willebrand factor released from the endothelium. তাই না? কি করেছিলাম? এখানে মনে কর expose collagen fibers are there and this is a von Willebrand factor and this one is connected to the exposed collagen and then only platelet surface receptor. কোন রিসেপ্টর? চারটে রিসেপ্টরের নাম বলেছিলাম আপাতত, চারটে না মোটামুটি 6টা বলেছি। একটা বলেছিলাম প্লেটলেট গ্লাইকোপ্রোটিন 1B, একটা 1A 2A, একটা 2B 3A, P6 ভেরি গুড GP6, তারপরে বলেছিলাম P2Y12 মানে P2Y12, PAR1 রিসেপ্টর এন্ড থ্রম্বোক্সিন রিসেপ্টর। এই 7টা রিসেপ্টরের নাম তোদের কাছে আগের দিনকে বলা হয়েছিল। Now what is the purpose of glycoprotein 1B? Glycoprotein connects with the von Willebrand factor that is connected to the exposed collagen. Then only adhesions will start. So already told you কি বললাম? কি বললাম আমি? Platelet to non-platelet surface is a platelet adhesion. এই যে von Willebrand factor তো একটা non-platelet surface. তাহলে প্লেটলেট, এখানে একটা প্লেটলেট আছে, এখানে একটা রিসেপ্টর আছে, and then এখানে von Willebrand factor আছে, আর এ বেটা কোলাজেনের সঙ্গে এক্সপোজ কোলাজেনে অ্যাটাচ। এই রিসেপ্টরকে বলছি GP1B, এটাকে বলছি von Willebrand factor, তাই তো? And other receptor that is the 2A and 1A or 1A 2A and the GP6 is directly to the exposed collagen. তাহলে 1B হলো von Willebrand factor দিয়ে আর 2B 3A হলো এই 2A 1A and GP6 হলো ডাইরেক্টলি। ডাইরেক্টলি মানে কি? এখানে মনে করো একটা প্লেটলেট আছে, এ বেটা GP6, আবার এখানে একটা প্লেটলেট আছে, এ হচ্ছে GP1A and 2A। পুরোটাই হেমোস্ট্যাসিসের রিসেপ্টরের খেলা। and believe me, all the medical science and medicines are related to our receptors. So whenever you are dealing with any receptor chapter, তোদের কি স্টার্ট হয়েছে? রিসেপ্টর চ্যাপ্টার স্টার্ট হয়েছে? হ্যাঁ না না, রিসেপ্টর একদম জেনারেল ফিজিওলজি। কে পড়াচ্ছে আমি জানি না। জেনারেল ফিজিওলজি, সেল মেমব্রেন, রিসেপ্টর, টাইপস অফ রিসেপ্টরস। So those chapters are very much important for your whole life. দেখছিস তো বারবার তোদের রিসেপ্টর আসছে, রিসেপ্টর ছাড়া কিচ্ছু হয় না, রিসেপ্টর ছাড়া কোনো মেডিসিন কাজ করে না। So whenever which receptor will act depends upon the type of receptors. ঠিক আছে, যদি আমাকে বলা হয় রিসেপ্টর ক্লাস নিতে আমি নিয়ে নেবো, কোনো অসুবিধা নেই। So platelet adhesions means platelet to non-platelet surface. এই যে হচ্ছে প্লেটলেটের সঙ্গে কোলাজেন, প্লেটলেটের সঙ্গে প্লেটলেটের 1B এর সঙ্গে von Willebrand factor, এখানে কি প্লেটলেট টু প্লেটলেট হচ্ছে? There is no scope of having any platelet to platelet combinations here. দ্যাট কেউ লাগেনি, কোনো প্লেটের সঙ্গে, শুধু প্লেটলেটের সঙ্গে নন প্লেটলেট সারফেস লাগছে। নন প্লেটলেট সারফেস লাইক ভন ইলেভেন ফ্যাক্টর, নন প্লেটলেট সারফেস লাইক এক্সপোজড কোলাজেন। Collagen must be exposed before the adhesions. Before, if not exposed, then endothelium থেকে release হওয়া von Leeuwenhoek factor does not act on the contact or impact collagen. Exposed collagen means it is a damaged collagen. And you remember that layers of the any blood vessels have 3 layers, তাই তো? কি কি? মোটামুটি ভাবে collagen, smooth muscles and endothelium. Endothelium. So these are the platelet adhesions, and platelet adhesions mean platelet connections with platelet to non-platelet surface. Right? Now, come to the clinical point. Before starting in previous class, I have given a patient note. The patient having petechial rash, fever, right? Purpuric rash, etc. given. In that basis, I came to the point that platelet deficiency must be there. So I come to the point in a platelet, how it is formed, what is that, and what is the granules are there. এগুলো মনে রেখেছিস সব? সব গুলো একদম ভুলে শেষ। So platelet, whenever you are dealing with any platelet combinations or platelet related diseases, then we have to come into the clinical scenario in 2 types. One type is a skin rash, skin rashes having bruise, petechial rashes, purpura, এই টার্মগুলো আস্তে আস্তে করে অভ্যাস কর। So these rashes mean some problems of some platelet, and this is due to the platelet plaque formation only. মানে প্লেটলেট প্লাক ফরমেশনসটা হতে পারছে না, দ্যাটস ওয়াই দিস ইজ হ্যাপেনিং। বাট হোয়াট ডু ইউ মিন বাই হেমোস্ট্যাসিস? Hemostasis has 3 parts. One is vasoconstriction, second is primary platelet plaque formations, third is coagulations. Very good. In the platelet plaque formation, there are 4-5 steps. One is platelet adhesions, then platelet activation and secretion or release, then platelet aggregation that will start from today, and then the platelet temporary plaque formations, then after that coagulations. What do you mean by coagulations? Coagulation means platelet plaque এর উপর fibrin stands. So fibrin stands means it is the coagulations. Problem is that if this process continuous and continuous and continuous, then কি হবে? একটা থ্রোম্বাস তৈরি হবে, হতেই থাকবে। Then ultimately this thrombus is dislodged from that area of damage and goes to the other microcirculation, and that may cause ischemia, damage, stroke, microartery infarction, etc. So there must be some balance. There must be some balance. Balance of what? Balance of between the coagulation and anticoagulant therapy. এমন নয় যে একটা জায়গায় কাটলো তো থ্রোম্বাস তৈরি হয়েই যাচ্ছে তা নয়। That means our 4th term will be that the fibrinolysis. তাহলে আজকে আমি 4টে কথা বললাম। কি কি বললাম? vasoconstrictions, then primary plaque formations, then the coagulations, then fibrillation. That is also essential because after the damage, injury damage and the repair of this damaged area, then their flow should be smooth. তাই না? এইখানেতে একটা ব্লাড ভেসেল কেটে গেছে, ব্লাড আসছিল বলে আমি এখানে প্লেটলেট প্লাক ফরমেশনস করেছিলাম, আমি কোয়াগুলেশনস পড়াবো, তখন দেখবি এখানে ফিব্রিন স্ট্যান্ড তৈরি হবে। বাট ইফ ইট ইজ কন্টিনিউ টু প্রডিউস দেন দিস উইল বি ফর্ম এ থ্রোম্বাস। তাহলে কি হলো? আমার তো ব্লাড সার্কুলেশন যেতে পারছে না। So that must be clear of after the repair of that area. কে রিপেয়ার করবে? প্লেটলেট ডিরাইভড গ্রোথ ফ্যাক্টর। কোত্থেকে বেরোয়? alpha granules. Now question is that what are the granules? Already told you alpha granules and dense granules, right? সব ভুলে যাবি, 3-4টে আলফা গ্রানুলস থেকে ভুলবি না। নাম্বার 1 কি বলেছিলাম? von Leeuwenhoek factor. নাম্বার 2 fibrinogen. Number 3, platelet derived growth factor. Number 4 is platelet factor 4. And dense granules এর ফর্মুলাটা খুব সুন্দর, SAC, SAC, dense granules. For the dense granules, dense granules কে অনেক সময় ডেল্টা granules ও বলা হয়. SAC means serotonin, S for serotonin, A for ADP, C for calcium. So these are the dense granules. তিনটে জিনিস ভুলবো না. So what are those? These are these: serotonin, ADP, and calcium. Now come to the point in the platelet aggregations, because during the platelet plaque formation or primary hemostasis, this is called primary hemostasis, right? What do you mean by secondary hemostasis? Coagulations. And after that, fibrinolysis. That is essential to clear off the thrombus after the repair of the blood vessel. যদি রিপেয়ার হয়ে যাওয়ার পরেও এখানে এটা থেকে যায়, তাহলে দ্যাট মে ট্রান্সফর্ম কোথায় যাবে? বিভিন্ন জায়গায় গিয়ে বিভিন্ন রকম প্রবলেম করতে পারে। ইট গোজ টু দ্য হার্ট অ্যান্ড দ্যাট মে কজ দ্য মাইক্রোডিয়াল ইনফাকশনস। তোরা জানিস অনেক রিলেটিভের হয়েছে। সো দিস মাস্ট বি ডিসলভ আফটার দ্য রিপেয়ার। আমি এতক্ষণ কেন করেছিলাম? টু রিডিউস দ্য blood loss. সব কিছু বেরিয়ে যেত। Now, clinical scenario. One clinical scenario, I am telling that only the rashes are appearing and the problem appears in the platelet plaque formations. Another scenario I am giving, suppose a patient come with joint swelling plus severe form of rashes or severe ecchymosis. জয়েন্টে মনে কর নি জয়েন্টে ফুলে নিয়ে চলে এলো। সাপোজ ইউ আর ডিলিং ইন ওপিডি, পেশেন্ট কাম উইথ সিভিয়ার সোয়েলিং অফ জয়েন্ট পেন, মে বি বাইল্যাটারাল, মে বি ইউনিল্যাটারাল। দ্যাট মিনস একদিকেও থাকতে পারে, দুদিকেও থাকতে পারে। অ্যান্ড উইথ সাম একাইমোসিস। With the seeing this ecchymosis, in your mind must be there that there is something happening in the hemostasis part. Now another patient, one patient is dealing with such that petechial rash, purpura rash without any joint swelling. But another patient having the deep rashes, extensive rashes along with the joint swelling. So what is happening? Happening is that one patient having the superficial bleeding হচ্ছে এইটা, this is called superficial bleeding, okay? And this joint swelling, after the examination you saw that swelling is due to the blood collections surround the blood in joint, blood আছে, that may present with the muscle hematoma also, muscle এর ভিতরে blood আছে, may present in the intracranial bleeding also, মাথার ভিতরে blood আছে. So in this way this happens. That means there is something in the endothelium that helps us to keep our blood in the fluid state. তাই তো? আমার তো সবারই তো এখন ফ্লুইড স্টেটে আছে, হোপফুলি। জানি না আমার কি এখন হয়ে আছে। স্ট্রেস তো আমাদের আছেই, and stress may cause any types of anticoagulant factors. Come to the point. Superficial bleeding কেন হচ্ছিল? This way. And this is called the deep bleeding. So whenever you are thinking about the deep bleeding, that means coagulation cascade gone. Coagulation cascade gone, that is the secondary hemostasis gone. Up to this is the primary hemostasis problem was there. For that superficial bleeding, suppose a patient come with the mucosal bleeding, gum bleeding, অনেক সময় আছে আমাদের বাচ্চাদের প্রায় আছে gum bleeding, that may be in many cause, that may be due to local infection, that may be due to the platelet function problem, that may be the platelet count less, that may be due to the dengue, that may be the ITP, that may be the aplastic anemia. So everything can cause this type of superficial bleeding. But if Any patients come with the joint swelling, having some bleeding under the joint, and these patients may termed as a hemophilia. Now, termটা জানিস তোরা কেউ? Hemophilia. So hemophilia patients may come with this such type of rash, ecchymosis, extensive ecchymosis all throughout the body, as well as joint swelling, may be bilateral or unilateral. After the aspiration of this joint site, you can get the blood only. That means our secondary hemostasis system is damaged. In that case, the platelet doing the platelet function is irrational. Platelet function থেকে কিছু হবে না. Now, platelet plaque formations is having adhesions, activations, and aggregations. Mainly three parts. After the adhesions, that means platelet to non-platelet surface connections. হচ্ছিল? And then the platelet activation. কি করলো? Activation এ কি করে? 1, 2, 3, 4. চারটে পয়েন্ট বলেছিলাম। বল অ্যাক্টিভেশনে কি করে? হ্যাঁ, রিলিজ, ভেরি গুড, নাম্বার 1। নাম্বার 2, conformational changes, very good. Number 3, very good, that is a Philadelphia, Philopedia. This is a এখান থেকে এরকম শেপ চেঞ্জ করে দিচ্ছে, increases the surface area to cover the maximum damaged area. Number 3, number 4, yes, attachment of, yeah, coming. Now this point I will start. যে কথা যে বলছিস বেরিয়ে যেতে পারিস, আমি দিয়ে দেবো, আমি কিন্তু পার্সেন্টেজ দিয়ে দেবো, কোনো অসুবিধা নেই। Don't come in my class with for the percentage only. Please leave your class, no problem. I will take care of your exam. So this is the shape changes and release of granules, changes of conformational changes of 2B3A, remember 2B3A GP, এটার আরেকটা নাম আছে, আমি ইচ্ছা করে বলছিলাম না, ইন্টিগ্রিন আলফা 2 বিটা 3, মনে রাখতে পারলে ভালো। দিস আর দ্য মডার্ন নেম, দিস ইজ দ্য মডার্ন নেম। কারেন্ট জার্নালে আর GP 2B3A বলে না, তোদের বইয়ে আছে তাই দিলাম বলে, বাট এখন কিন্তু নাম হচ্ছে এটা, ইন্টিগ্রিন আলফা 2 and বিটা 3। So these are the conformational changes. কি হলো ব্যাপারটা? It releases the sac SAC, কোত্থেকে বেরোয়? Dense granules. A means ADP. ADP লাগে কোথায় বাবা? ADP কোথায় লাগছিল? There is a receptor. Yes. P2Y 12 ball, 12. Because this P2Y having 14 types of receptor, 1 to 14. But here I am dealing with the 12. P2Y receptor 12. To make it interesting for you, you have heard already that some of your relatives, maybe father, maybe parents, maybe grandfather, using the aspirin and clopidogrel. কেউ শুনেছিস? Aspirin and clopidogrel combinations দেয়া হয় for the patient of heart, ischemic heart disease, coronary heart disease. ঠিক আছে? That clopidogrel is a receptor blocking of this P2Y12 plus 12. Aspirin and coming later. Another 2 things will come after the activation of that platelet. কি বলেছিলাম? Yes, very good. Thrombin, then thromboxane A2, very good. Thromboxaneর জন্য thromboxane receptor, thrombinের জন্য বলেছিলাম PAR1 receptor, তাই তো? Platelet activated receptor 1, thrombin and ADP for the P2Y12. P2Y12 না, P2Y12 বলাটাই ভালো। কেন? কারণ P2Y is a receptor. There are 1 to 14 types. ADP binds mostly with P2Y1 and more aggressively P2Y12. That's why I'm dealing only the P2Y12. Boy nahi. Then ADP will bind to this, means it inviting the others platelets for activation. এক নম্বর। দ্বিতীয় কি করছিল, যদি এটা এখানে লেগে এটা অ্যাক্টিভেট হয়ে গেল, দিস প্লেটলেট নিউ প্লেটলেট, ওখানে তো প্রচুর প্লেটলেট, নিউ প্লেটলেট অ্যাক্টিভেটেড ভায়া দিস অ্যাকশন। Activation means one of the point was there, that is the conformational changes of the receptor. কি receptor? আবার ভুল বলছি, 3 এর পরে A, তাহলে আমার রিসেপ্টর কি হলো এখানে, জিপি, এটাই বলছি 2B3A বা ইন্টিগ্রিন আলফা টু বিটা 3। কনফর্মেশনাল চেঞ্জেস হলো আফটার দ্য অ্যাক্টিভেশনস। যেই কনফর্মেশনাল চেঞ্জেস হলো, দেন আলফা গ্যানিউলস থেকে কি বেরিয়েছিল বললাম, ভুলবি না, ফিব্রিনোজেন, ভন 11 ফ্যাক্টর, রাইট? নাও একটু এখান থেকে সরে আসি। তাহলে দিস fibrinogen, suppose this is a fibrinogen and this one is a von Leuven factor, suppose is a shape that connect with this GP2 to B3A, কে আসবে, fibrinogen চলে এলো, কোত্থেকে এলো, আলফা গ্যানিউলস। কিভাবে এলো, আফটার অ্যাক্টিভেশন। কেন অ্যাক্টিভেশন হলো, আফটার অ্যাডিশনস। কিভাবে অ্যাডিশন হলো, additions between the three sites. One is directly by 1A 2A receptor, one is GP6 receptor, one is through the von 11 factor receptor, that is the GP1B. GP1B. In this context, if any patient having congenitally absence of this GP1B receptor নেই, মনে কর ওর নেই, ও নিজে এখন জানে না যে ওর নেই, হয় নাই কোন, suppose তো নেই, what will happen? That may happen in any time during any surgery or trauma, the bleeding is being continue and continue and continue. কেন, 1B কি করছিল, ডাইরেক্টলি von 11 এর সঙ্গে কানেকশনস করছিল for the adhesions, most important part of the adhesions, and that disease is called Bernard-Solier syndrome. That is called Bernard-Solier syndrome or BSS. There are different types are there, 1, 2, 3. I am not going details. I have came across one patient having this Bernard-Solier syndrome. That patient having the deficiency or absent is GP1B, right? In this context also, if any patients having the deficient or absent of the ওই রিসেপ্টরটা, ওই যে GP2B3A যদি absent থাকে, that disease is called Glanchman syndrome. If this is absent or less, then this is called Glanchman, MANN, Glanchman syndrome. এই দুটো কোশ্চেন পড়ি দিলাম, কারণ এই দুটো ভাইভাতে অনেক এক্সামিনার জিজ্ঞেস করে। এবারে যারা এক্সটার্নাল এসেছিল তারা জিজ্ঞেস করছিল, আনফর্চুনেটলি আমার ক্লাসে কেউ শোনেনি, নট এ সিঙ্গল অ্যান্সার দিতে পারেনি, বাট আই হ্যাভ গিভিং ইন দিস টাইপ লেকচার এভরি ইয়ার, সো আই পুট দিস বিকজ দিস ইজ দ্য ভেরি ফেভারিট টাইপ অফ এনি টাইপ অফ সিনিয়র এক্সটার্নাল। So Bernard-Solier syndrome is the deficient of the GP1B, and 2B3A deficiency is called Glanchman syndrome. Remember, probably it is also given in your book. আছে, খুলেছিস কেউ বই? খুলিসনি, বেশ ভালো কথা, খুলিস না, সব পরীক্ষার সময় টেক কেয়ার করবো, বই খোলার কোনো দরকার নেই। 9 জনের মধ্যে, এই যে 9 জন গেছে, এই 9 জনের মধ্যে তার পরীক্ষা সেই হয়তো আমিই নেব, যদি বলতে না পারে আমি কিন্তু ইয়ার লস দেবো, মানে ইয়ার লস। আচ্ছা, সো আপ টু দিস কি কি শিখলাম, দ্যাট ইজ অ্যাডহেশন অ্যাগ্রিগেশন। এখন অ্যাগ্রিগেশনে ঢুকিনি, কিন্তু অ্যাগ্রিগেশনের কাছাকাছি চলে গেছে। অ্যাগ্রিগেশন মিন্স প্লেটলেট টু প্লেটলেট কানেকশনস, অ্যাডহেশনস মিন প্লেটলেট টু নন প্লেটলেট কানেকশনস। Now come to this way, concentrate this part. After the activations by these three receptors of the platelet activations, the conformational changes is a one of the part. Conformational changes of the receptor, that is the 2B3A, and this 2B3A, another name is integrin alpha 2 beta 3. So this receptor is connected to the fibrinogen as well as von Willebrand factor also. মনে করো আমি আরেকটা আমি এখানে জিপি 2B3A আঁকলাম, আর এইটা হচ্ছে আমার von Willebrand ফ্যাক্টর। তাহলে এটা হচ্ছে ফিব্রিনোজেন কোত্থেকে আসছে? আলফা গ্যানিউস থেকে। এটা হচ্ছে আমার von Willebrand ফ্যাক্টর, কোত্থেকে আসছে? প্লাস এন্ডোথেলিয়াম। If damaged endothelium is there, von Willebrand factor will be released. That's why this adhesion is occurring. So von Willebrand factor source is both. Von Willebrand factor source is both endothelium and platelet. Remember, in the endothelium, it is stored in a body that is called oval palate body. Short note দিতে পারে, দেখেছিস? পড়াতে থাকলে পড়াতেই থাকবো। palate, PALADE body। কি জিনিস এটা? এন্ডোথেলিয়ামের মধ্যে থাকে, ইজ প্রেজেন্ট ইন এন্ডোথেলিয়াম। কি থাকে এর মধ্যে? von Willebrand factor। von Willebrand factor স্টোর থাকে। মাল্টিমার ফরমেশন, মাল্টিমার টাইপের অফ von Willebrand factor। von Willebrand factor if deficient is causing the von Willebrand factor diseases। von Willebrand disease, this is called von Willebrand diseases। তাহলে তিনটে ডিজিজ অলরেডি বললাম, তিন চারটে আমি বলেছি। নাম্বার ওয়ান কি বললাম? যে ওয়ান টাইপ অফ র্যাশেস, দ্যাট ইজ পেটিচিয়াল র্যাশ এন্ড পারপিউরিক র্যাশ, দ্যাট may cause the primary platformation of the superficial bleeding. Another patient is coming with the joint swelling and under the bleeding in the joint, and these are the happening in case of hemophilia due to the coagulation defect problem. That is the coagulation defect problem. Another is the GP1B deficient, that is called Bernard-Solier syndrome, and GP2B3A, that is called Glanzmann syndrome, right? And now I am telling the von Willebrand factor disease deficiency, a von Willebrand disease, right? So oval palate body is present in the endothelium, stored. এখানে কে থাকে stored? না, von Willebrand factor. So von Willebrand factor coming to this way. Now GP2B3A, and this is the GP2B3A, and another is a von Willebrand factor, and this is a fibrinogen, right? Clear? এখানে কোনো কনফিউশন নেই। Now another platelet are there, এ তো শুধু একে অ্যাক্টিভেট করেনি, that causing the other platelet activations also occurring simultaneously. So suppose this is another platelet having another conformational changes of this, having conformational change of this receptor, and these are connected. This is called platelet aggregations. So platelet to platelet connections হচ্ছে through via this fibrinogen or as well as von Willebrand factor. তাহলে বুঝতে পারছিস একটা প্লেটলেটের সঙ্গে জোড়া লাগছে। দেখ আমার যেখানে কেটেছিল, সেখানে আমার প্লেটলেট লাগছে। এবার আমার প্লেটলেট লাগছে, একে অপরের সঙ্গে প্লেটলেট লাগবে। Exposed collagenous there, adhesions are also present. So it's like big version is this. Here is a smaller version and the big version is this. কি হচ্ছিল তাহলে? কি হলো তাহলে প্লেটলেটে? Aggregations হলো। How? After the conformational changes of the 2B3A, it is connected to the fibrinogen and the von Willebrand factor present in the circulations. That is released from the alpha granules as well as von Willebrand factor also released from the endothelium, damaged endothelium. And then the other platelets, এ তো শুধু একটা প্লেটলেট কে অ্যাক্টিভেট করছে না, এই ADP receptor not a single, each and every receptor there Each and every platelet has a receptor. This is the P2Y112, and the PAR receptor and the thromboxane receptor is present in each and every platelet. So it going platelet activation in more platelet activations. Suppose this is a one type of activated platelet, and that is causing the conformational changes of the 2B3A, and then it's connected to through key fibrinogen or through key von Willebrand factor. This is called platelet aggregation in this way. The platelet adhesions means connections to the platelet to the non-platelet surface, that is this one. And these are the platelet connections between these platelet is aggregations. So platelet adhesion, activations, aggregations, complete. Any confusion at there? Now the fourth thing is that the fibrin coagulation cascade. In the coagulation cascade, ultimately form is the fibrin fiber, right? The fibrin fiber ta kiভাবে হবে এইভাবে হবে, তাই তো? এই যে mesh like structure is happening, this is a fibrin. আমি যে ছোট ছোট যেগুলো আঁকছি, these are the fibrin, these are the fibrin. তাহলে আর ব্লাড আসতে পারবে? But remember, in this trap, this is the net, is a mesh. Not only platelet is present, also some RBC, WBC may be present. So all throughout this way, having the RBC platelet, RBC, suppose RBC there, একটা দুটো থাকলো, একটা দুটো WBC থাকলো, okay? So these are called the thrombus in our outside the body. It is outside our body, it is called clot. This is called clot. So this fibrin is formation is essential for the coagulation or secondary key hemostasis. Very good. Short note তো দেবেই দেবে। প্রাইমারি হেমোস্টাসিস বলতে কি বোঝে, সেকেন্ডারি হেমোস্টাসিস কি বোঝে, তাহলে কি বুঝলি এতক্ষণ ধরে? বুঝলাম যেটা আমার ফোকাস থাকবে দুদিকে, একটা থাকবে প্রাইমারি প্লেটলেটের দিকে, প্রাইমারি প্লেটলেট প্লাক ফর্মেশন আর প্রাইমারি হিমোস্টাসিস, আর একটা থাকবে বা শুরু হচ্ছে এবারে দ্যাট ইজ কোয়াগুলেশনস। আমার ওয়ান টাইপ অফ পেশেন্টস মে কাম উইথ আ মিউকোকিউটেনিয়াস ব্লিডিং, সুপারফিশিয়াল ব্লিডিং ডিউ টু দিস primary hemostasis problem that may be due to the platelet functionless or platelet countless, thrombocytopenia or thrombocythemia. Two is different thing. Thrombocytopenia means reduced count of platelet, and thrombocythemia means functional problem of thrombocythemia. asthenia এখানে ও thrombocythemia is called functional problem. Another called is called thrombocytopenia. Thrombocytopenia means reduced platelet. Here is called functional problem. Function problem. So in this way, this platelet is a functional problem. Now for remembering you in clinical entity, thrombocytopenia platelet count reduce. Kisi kisi hoy? Dengue te hobe. Taই na? Any sorts of infection hote pare. And also it is present in the aplastic anemia. Why? Because platelet is formed from the bone marrow. If bone marrow failure is there, then the platelet count will be less, because platelet is a megakaryocytic cell part. Right? So megakaryocyte. So is in this case aplastic anemia is also be considerations. Aplastic anemia is very common. And now the function এর জন্য already I told you two diseases. One is Bernard-Solier syndrome, that is a deficient or absent of the GP, that means glycoprotein 1B receptor. This is a Bernard-Solier syndrome. Another is a Glatchman syndrome, that is 2B3A receptor problem or receptor deficiency or absent is called Glatchman syndrome. That means functional problem is there, right? Any confusion is that? No. So after the additions, activations means 4 points are there: releasing, conformational changes, shape changes, as well as releases. Yes? Yeah. So in this case, if conformational changes is there, then the fibrinogen and von Willebrand factor connected to the conformational change receptor. There is another platelet also, another platelet. So these are going on. এমন নয় যে এখানে থেমে গেল, এইখান থেকে আবার একটা রিসেপ্টর, আবার একটা von Willebrand factor, then again a receptor, again a platelet. In this way, this is going on. Aggregation is going on. Platelet to platelet connections is going on. So this size is increasing. After that, if any, তাহলে আমার দরকার কেন হলো? আমার তো এই প্লেটলেট অ্যাগ্রিগেশনটাই আমার হলো, ভালো হতো। তাহলে আমার কোয়াগুলেশন why it is needed? আমার দরকার কেন হলো? Why? আবার কোয়াগুলেশন হবে, তারপর ফিব্রিনোলাইসিস হবে। আমার দরকার কি আছে? আমার দরকার আছে because in case of small injury, primary hemostatic is enough. But in case of large injury, then fibrin may work is efficiently work for the accumulated defect more efficiently. So create the efficiency of this damaged area to corrections so that the coagulation cascade is must. I am telling the term coagulation cascade. That's the meaning of this cascade. So coagulation cascade, there will be formations of the fibrin monomer, then fibrin polymer, then mesh-like polymers will be formed to formations of this thrombus along with some sorts of RBC and WBC intact inside the thrombus. But this thrombus does not going forever. হতেই থাকলে that causing the thrombus and blockage of the ideal this. তাহলে এটা ড্যামেজটা পূরণ করবে কে? এতক্ষণ ধরে ব্লিডিং করছিল, কে পূরণ করবে বাবা? স্মুথ মাসেল। কিভাবে? প্লেটলেট ডিরাইভড গ্রোথ ফ্যাক্টর। কোত্থেকে বেরোয়? আলফা গ্রানিউলস। So these are the platelet derived growth factor. নামটাই তো তার growth of what? Growth of endothelium cells. So these are the damage repair by this platelet derived growth factor is done. When it is done, then there is no need of any thrombus at this present. If it is present, then this goes to the any types of microcirculation and causing the ischemia of some organs like brain, heart, liver, kidney, etc. That's causing the damage. So that must be dissolved by what? Fibrinolysis. Coming to the point, if time permits. So to this is platelet adhesions, activations, aggregations. I think this is clear to you and you can write a short note. আজকে বাড়িতে গিয়ে একটা short note লিখে ফেলবি। যদি লিখবি সেটাই পরীক্ষায় লিখবি। মানে সব ভুলে যাবি। But in this way, you never came across with your textbook. It's very unfortunately. গল করে লেখা আছে। তোরা শুধু মুখস্থ করছিস। মুখস্থ করার কোনো জিনিস আছে? কিচ্ছু নেই, নাথিং এলস। শুধু রিসেপ্টরের নামগুলো মুখস্থ করার দরকার আছে। রিসেপ্টর আর 1B, GP6, GP1A 2A, GP2B 3A, P2Y 12, PAR1 and thromboxane receptor. Nothing. আর কিচ্ছু বলবো না। প্লেটলেটে 100 টাইপস অফ রিসেপ্টর দেয়ার and in my mind 30 রিসেপ্টর এখনো আছে। তাহলে আমি তোদেরকে কটা বলেছি? only 7 রিসেপ্টর। So 7 receptor at least মনে রাখা দরকার because this receptor is came across with drug also in pharmacology in the second year classes. Anyhow, so this fibrin is must because of large gap, large wound injury and the patient will be like hemophilia, Christmas disease, liver disease. কেন বললাম liver disease? Because the coagulant factors are released from the liver disease. Coagulant factors are come from the liver. So if any patients come with the chronic liver patients that may come across liver problem. If any patients come with the liver problem, then we always search for any coagulation defect is present or not. Number one. Number two is that this fibrin formation is started from the fibrinogen. কোত্থেকে এসেছিল? Alpha granules, right? Now, so hope you are enjoying to some extent both physiology, theoretical and also practical. And that is very important clue that you are not going to be a layman or any physiologist, you are going to be a doctor. So always assess what to learn and what to apply. So now in your mind is that two types of bleeding are there. That is a superficial bleeding and the deep bleeding. If superficial bleeding is there, that means primary hemostasis is in action. If it is deep bleeding, then coagulation cascade is important. No? So আমি কি বললাম? ফিব্রিনোজেন থেকে আমার ফিব্রিন তৈরি হবে। এইটুকু। বাট এটা কি এমনি হয়ে যাবে? নো। কে স্টিমুলেট করবে? থ্রম্বিন। কে করবে এটাকে? থ্রম্বিন। থ্রম্বিন কি এমনি হয়ে গেছে? নো। বিন, প্রথম বিন থেকে থ্রম্বিন, রাইট? নাও you already know in your class 12 chapters, I like that you know that the names of the clotting factors, জানিস কে কে? Names of the clotting factors কে কে জানিস? 1 to 13 হচ্ছে clotting factors are there, জানিস না? Anyway, so that is represented in a Roman numerals, that is fibrinogen is 1, প্রথম বিন is 2, বুঝতে পারছিস? কেন এগুলো 1 2 3 4 5 6 7 8 9 10 11 12 হলো? ডিউ টু দ্য ডিসকভারি। নাম্বার 1 ডিসকভার্ড ফার্স্ট, that is 1, প্রথম বিন ডিসকভার্ড after that, that is 2, then number 3, what do you mean by number 3? Remember এখানে নাম্বার 3টা লিখে রাখলাম। নাম্বার 4 is a calcium, এগুলো বই আছে দেখবি, আমি আর ডিটেলসে যাব না এটা। নাম্বার 5 কিছু নাম আছে, 6 নেই, একমাত্র ফ্যাক্টর যেটা নেই কাজে লাগে না, দ্যাট ইজ 6, 7 is there, 8 is there, 9 is there, 10 is there, 11 12 13 is there, right? So fibrin is here, এইটা যেটা হচ্ছে সেটা হচ্ছে ফিব্রিন, these are the fibrin। ফরমেশনটা তো ইজি নয়, ফিব্রিনোজেন থেকে ফিব্রিন হয়ে গেল স্যার, এটা সুন্দর হয়ে গেল এখানে, তা নয়। দিস ইজ দ্য কাসকেড অফ রিঅ্যাকশন। কাসকেড মিন্স ঝর্ণার জল দেখেছিস, একটা পাহাড় থেকে আরেকটা পাহাড় পড়ছে, আরো জোর নিচে যখন পড়ছে হুশ করে বুম। সো লাইক দিস, this step is a boom, before that something is happening in the previously, that is remember like why, that is remember like why, because coagulation cascade pathway is a 3 pathway, one is intrinsic pathway, another is a extrinsic pathway, one is a common pathway. So this is the intrinsic pathway, and this is the extrinsic pathway, and this is the common pathway, and in a common pathway this is a part, তাহলে প্রথম বিন and thrombin, তাহলে প্রথম বিনকে কে অ্যাক্টিভেট করলো? হিউজ চিন্তার ব্যাপার, এমনি তো হয়ে যাবে না। প্রথম বিনকে অ্যাক্টিভেট করলো XA, এটা কে? মেসি, চিনিস তো? হ্যাঁ, কি থাকে জার্সিতে? 10 থাকে না? আমি এখানে কি লিখলাম? এ লিখেছি একটা। এ মিনস অ্যাক্টিভেটেড ফ্যাক্টর 10। ফ্যাক্টর 10 এর নাম হচ্ছে, মনে রাখার দরকার নেই, স্টুয়ার্ট পাওয়ার ফ্যাক্টর, দরকার নেই। ফ্যাক্টর 10, তো ফ্যাক্টর 10 is a pivotal role to formation of fibrin, but মেসির প্রবলেম হচ্ছে মেসি একা কাজ করে না। কাজ করে একা? মেসিকে খেলানো হয়, দেন মেসি উইল গোল। মেসি একা খুব কম খেলেছে, তাহলে এর সঙ্গে আমার ফ্যাক্টর 5 আসবে, কে? 5A। আর কে আসবে? ডেন্স গ্র্যানিউলস থেকে একটা বেরিয়েছিল না, কি? SAC। হোয়াট ডু ইউ মিন বাই সি? ক্যালসিয়াম, লিখে ফেল, ক্যালসিয়াম। অ্যানাদার ইজ এ ফসফোলিপিড, কোথায় থাকে? প্লেটলেটের সারফেসে, মনে আছে যেখান থেকে থ্রম্বোক্সিন তৈরি হয়েছিল? প্লেটলেটের আমি বলেছিলাম প্লাজমা মেমব্রেন ইজ দেয়ার হ্যাভিং সাম লিপিড বাইলেয়ার, সো দিস আর দ্য ফসফোলিপিড ইজ প্রেজেন্ট here. So now this is it is a committee, congressional committee, কংগ্রেসের কমিটি যেমন হয়, কংগ্রেশনাল, কংগ্রেস পার্টি নয়, আচ্ছা কমিটি, this is a committee having the Messi inside the committee, and this is called prothrombinase. This is called প্রথম বিনেজ। এটা এনজাইম হয়ে গেল, কিন্তু কি কি নিয়ে হলো? একটা নাম হলো মেসি, অ্যাক্টিভেটেড ফ্যাক্টর 10, ফ্যাক্টর 5, ক্যালসিয়াম, ফসফোলিপিড। বক্সের মধ্যে আমি দিয়েছি লিখে। এইটাই একে অ্যাক্টিভেট করে, মানে প্রথম বিন থেকে থ্রম্বিন করতে অ্যাক্টিভেট করে। তাহলে রিমেম্বার, fibrinogen to fibrin requirement is a thrombin. Requirement of prothrombin to thrombin? Prothrombin must be activated by this committee having MESI, factor 5, calcium, phospholipid, and then activates these reactions to thrombin. Now question is now arises the how XA is formed. I am written XA, that means activated form. The somehow it was inactivated form. তাহলে আগে এটা inactivated form এ ছিল শুধু X, একে কে অ্যাক্টিভেট করছে বাবা? ইন্ট্রিনসিক এন্ড এক্সট্রিনসিক এর ফ্যাক্টরস গুলো কি কি কিভাবে রাখবো মনে? মনে রাখবো 10 মিন্স এখানে 7 ফ্যাক্টর আর 3 ফ্যাক্টর। খুব সহজ, এভাবে যে বলছি এটা বই পড়বি এবার দেখবি জলের মতো হয়ে যাবে। 7 আর 3 কত হয়? 10। তাহলে এই দিকটা মনে রাখলাম 10। 7 মিন্স 7 ফ্যাক্টর, তাহলে এটাকে রোমান ওয়ার্ডে লিখবো 7 ফ্যাক্টর। এখানে লিখেছিলাম দেখ ফ্যাক্টর 3 মনে আছে? Factor 3 is called tissue factor. This is called tissue factor. Right? And this makes a combinations, makes a complex 7 and 3, and that activates the 10A to a 10 to 10A. That is called extrinsic. Extrinsic pathway is fast because it is short but less efficient. But what do you mean by efficient? Intrinsic. কিভাবে? Remember the first thing. Whenever any damage to the endothelium, whenever damage in the endothelium, then only this process will start. Then exposed endothelium will be there. During the exposed endothelium, the clotting factors released from the liver is connected to the exposed endothelium. Endothelium তো ভেঙে গেছে, এন্ডোথেলিয়াম সেল ড্যামেজ হয়েছে, এখানে আবার এখানে একটা সেল ছিল এও এখানে ড্যামেজ হয়েছে। ওকে, সো দিস আর দ্য কানেকশনস অর কন্ট্যাকশনস টু এ কন্ট্যাক্ট ফ্যাক্টর দ্যাট ইজ কল্ড ফ্যাক্টর 12. অ্যানাদার নেম ইজ হেজমেন্ট ফ্যাক্টর। সো দিস ইজ ফ্যাক্টর 12. একটু আগে বলেছি coagulation is a cascade of reactions, means one step is having the more in the second step, about more, much more in the third, much more and in fourth, then it is like the boom. This is a boom. এইখানেতে হচ্ছে বোমটা ফাটছে, মানে ঝর্ণা জলটা পড়ে পড়ে এইখানেতে আসছে। আমার আলটিমেটলি এম কি? ফিব্রিন স্ট্যান্ড তৈরি করা। So 12. The 12 is connected to the exposed endothelium and that is activated form. After the connection with the endothelium, then it activates, কাকে করবে activate? কাকে করবে? ফ্যাক্টর 11. Then is causing factor 11 activations. এ আবার কাকে অ্যাক্টিভেট করবে? 10 কে আর নেই, 11 তারপর 12, 10 তো এখানে চলে এসেছে, 9. So 9. Then it is also activated, 9 activations. Now this 9 activated 9 factor means hemophilia problem. ওই যে বলছিলাম একটু আগে, জয়েন্ট সোয়েলিং, ডিপ জয়েন্ট, হেমাটোমা, these are the hemophilia. Hemophilia A and B is there. Factor 9 is a hemophilia B, also called Christmas disease. লিখতে চাইলে লেখ, নাহলে ছেড়ে দে। So this is a 9 activations পর্যন্ত হয়েছে। এখনো পর্যন্ত now till it's not activated that factor 10 করেছে কি? ফ্যাক্টর 10 কে অ্যাক্টিভেট করলো? এখনো করেনি। কে করবে? ফ্যাক্টর 9 ই করবে। অ্যাক্টিভেটেড ফ্যাক্টর 9 কানেক্টেড উইথ ভন উইলিভেন ফ্যাক্টরের নাম মনে আছে? এ বেটা একটা জিনিসকে ক্যারি করে, সেটা হচ্ছে ফ্যাক্টর 8। Von Willebrand factor released from both platelet and endothelium. I can understand your brain is going in different areas. বুঝতে পারছো? But still believe, step by step, I will discuss in later part. So this is the factor 8. Now this activated factor 9 along with activated factor 8 is both activated activates factor 10. তাহলে intrinsic pathway complete, extrinsic pathway 3-7 complete. Intrinsic pathway is a long, it is efficient but long lasting. It is not efficient but it is very short duration period. টিস্যু ফ্যাক্টর কেন হচ্ছে রে? একটা ব্লাড ভেসেলের টিস্যু বলতে কি কি বুঝিস? টিস্যু বলতে আমরা বুঝি ফাইব্রোব্লাস্ট অ্যান্ড স্মুথ মাসেল। আস্তে আস্তে অ্যানাটমি পড়লে জানতে পারবি। সো টিস্যু ফ্যাক্টর মিনস দুটো জিনিস বেরোয়, সেই নাম দুটো এখানে বলে দিই। নাম্বার ওয়ান ইজ এ টিস্যু থ্রোম্বোপ্লাস্টিন, and number 2 tissue phospholipid. So these are the factor 3 and this makes complex with the factor 7 3 10 হয়, এটা তো ভোলার কোনো জায়গা নেই। আর এখানে কি হবে খুব মনে রাখবো, 12 11 10 বাদ 9, তারপরে আসবে 8। বোঝা গেছে? 12 11 9 8, 9 আর 8 কম্বিনেশনে আমার এক্স কে অ্যাক্টিভেট করব। এক্স যেই অ্যাক্টিভেট হয়ে যাবে ও কিন্তু মেসি হয়ে যাবে। And whenever it is becomes messy, then it goes to a forming a prothrombinous complex. Prothrombinous complex কি কি থাকবে সেখানে? মেসি, activated factor 10, factor 5, calcium and phospholipid. Phospholipid is the source of the platelet surface. Platelet surfaces. Remember these things happening কোথায় হচ্ছে এটা বাবা? প্লেটলেট সারফেসেই হচ্ছে এটা। দিস ইজ হ্যাপেনিং ইন দ্য প্লেটলেট সারফেস। এখানেই হচ্ছে সব এগুলো এখানে হচ্ছে। আমি আলাদা করে বাইরে করলাম, বাট ইজ হ্যাপেনিং ইন দ্য প্লেটলেট সারফেস বিকজ প্লেটলেট প্লাক ফর্মেশন এন্ড দ্য কোয়াগুলেশন ইজ গোস সাইমালটেনিয়াসলি। বলেছিলাম না? তবেই তো থ্রোম্বিন পাচ্ছিলাম। এই যে আমি এইদিকে এঁকেছিলাম না, এডিপি, থ্রোম্বাক্সিন এন্ড থ্রোম্বিন। নাও মেসির এত পাওয়ার, this X, one molecule of activated X, that means factor 10, is produces 1000 molecule of thrombin, 1000 molecule of thrombin, and thrombin is called thrombin burst. Thrombin যখনই বেরোবে, it activates other factor also. A আবার factor 5 কে activate করবে, 7 কে activate করবে, 8 কে activate করবে, সব দিকে তার অ্যাক্টিভিটি আছে, ফিডব্যাক লুপ। আমি ওইদিকে ডিটেলসে যাচ্ছি না। আলটিমেটলি আমি কি তৈরি করলাম? ফিব্রিন তৈরি করলাম। কিভাবে? ইন্ট্রিনসিক ফ্যাক্টর, এক্সট্রিনসিক ফ্যাক্টর। এক্সট্রিনসিক ফ্যাক্টর 7 3, ইন্ট্রিনসিক ফ্যাক্টর 11 12 9 8, then activates factor 10. Ultimately is the boss, this is the common। তাহলে এখানে প্রেসিডেন্ট কে? প্রেসিডেন্ট হচ্ছে ফিব্রিনোজেন। ভাইস প্রেসিডেন্ট কে? প্রথমিন। তার উপরে কে কমিটি আছে? উইথ দ্য মেসি। এই তিনটে জিনিস ভোলা যাবে না, right? So this is the Messi having the calcium and phospholipid factor 5, activated factor 5. This goes into the activates the prothrombin to become in the thrombin. This thrombin activates the fibrinogen to become the fibrin, right? বোঝা গেছে? Now this fibrin is normally insoluble. Is soluble? No, this is soluble. আমি যা বলছি তাই লিখছি, soluble। তাহলে সলিউবল হলে এটা হবে। এখানে যদি সলিউবল থাকে তাহলে ও আটকাবে না। দ্যাট মিন্স ইট মাস্ট বি ইনসলিউবল। কে করবে? ফ্যাক্টর 13 বলেছিলাম। তাহলে সব ফ্যাক্টরের কাজ হয়ে গেল। ফ্যাক্টর 13 কল ফিব্রিন স্টেবিলাইজিং ফ্যাক্টর। তাহলে এখানে আসবে কে? এখানে আসবে ফ্যাক্টর 13। কি নাম তার? ফিব্রিন স্টেবিলাইজিং ফ্যাক্টর। ফিব্রিন স্টেবিলাইজিং ফ্যাক্টর। রিমেম্বার ইন দ্য কোভিড পিরিয়ড we got many of relatives got a report of D dimer। মনে আছে? তখন ডি ডাইমার নিয়ে প্রচুর হয়েছিল। তোর কি কোনো খবরও রাখিস না? একদম ফেস পুরো। Nobody knows about this term also. Okay, leave it. So I'm not going into details. So this is a soluble. After the stabilizing, it becomes insoluble, more stable. Then that is why it forms the polymers. প্রথমে তৈরি করে মনোমার ফিব্রিন, দেন ইট ইজ কল্ড পলিমার। মানে একটা বেরোলো, আবার একটা বেরোলো, একটা বেরোলো, একটা বেরোলো। বাট when the stabilizing factor come, then cross linking of the fiber becomes cross linking is cross-linking of fiber is important to make a meshwork to form a thrombus. হচ্ছে বোঝা গেছে? Now in short, so it is platelet adhesion, platelet aggregation, then the formations of the coagulation cascade. Cascade means one reaction increases the second reaction. Second reaction increases furthermore the third reactions. There are three pathways of the coagulation cascade. There is the intrinsic pathway, there is a one hand of the Y, and the other is a extrinsic pathway. Extrinsic pathway, two factors are important, that is the tissue factor and factor 7. This makes a complex and this activates the মেসির আগের স্টেজ, that is X, that is inactivated মেসি। মেসি তখনও মাঠে নামেনি, মাঠে নামতে গেলে তার সঙ্গে তিন চারটে জিনিস লাগবে, that is a platelet, a phospholipid, calcium and factor 5, right? So these are the important. এটা কেন important? This is called prothrombinous complex. It stimulates the prothrombin to thrombin. Why thrombin is important? Thrombin is important to fibrinogen to fibrin, and fibrin is important, and fibrin is formed in a soluble form, but insoluble form is important for the meshwork formations. So this is the requirement of the factor 13. I already told you that there are 13 factors are there. Now 3, 7 gone, 5 gone, 10 gone. Now we are coming across the 12. It is a Hedgeman factor or contact factor. The name is clear. Contact means which contact? Exposed endothelium. When it is exposed endothelium, then the factor 10 is released from the liver. All the clotting factors are mainly the released from the liver. And remember, these clotting factors are dependent on the vitamin K. That's why in the newborn period, we always, within the 1 to 2 minutes, we give 1 IM injections of vitamin K without knowing anything. Because we don't know whether the patient is present with Bernard-Solier syndrome, Gladner syndrome, we don't know. What is this happening? We don't know any factor is deficient, is present or not. So vitamin K dependent দেয়া হয় কেন? Because vitamin K biochemistry পড়বি is causing the gamma carboxylation of the glutamate, and that's causing the activity of the clotting factors. তাহলে vitamin K ছাড়া clotting factors activate হতে পারে না। After the activation of the 12, then it activates cascade with the ঝন্ডার মতো, that causing the factor 12, factor activated 12, then activate the factor 11, then factor কি হবে 9, then ultimately is 8 এর সঙ্গে von Willebrand factor খুব বন্ধুত্ব কেন? কারণ von Willebrand factor increases the half life of the factor 8, খুব সুন্দর বন্ধুত্ব। So these are in the activated form and the 9 activated form together, intrinsic pathway activate the factor 10 মেসি হওয়ার আগে। So then these ultimately goes to formation of the activated factor 10. Activated factor 10 along with calcium phospholipid factor 5 activated, then it is called the prothrombin to thrombin, thrombin is fibrinogen to fibrin, fibrin is a soluble form টাকে insoluble করতে গেলে factor 13 লাগবে, finish, আর কিছু নেই। তাহলে all you in mind is that is the vasoconstriction first. আচ্ছা তোরা জানিস কেন vasoconstriction হয়, কিভাবে হয়? একটা হচ্ছে নিউরোজেনিক পাথওয়ে, দ্যাট মিন্স এখানে তুই কেটে দিলি আমার, তাহলে কি হবে? এখানে আমার নার্ভ ফাইবারে পেন আছে, that pain reflex causing the vasoconstriction of the smooth muscles. Number 1. Number 2 is a smooth muscle itself releases the vasoconstrictor and causing the myogenic contractions. And also endothelium releases the endothelin, that is the vasoconstrictor. So in 3 ways vasoconstriction is happening. Number 1 part, vasoconstriction is very short period. Number 2 is a primary platelet formations, right? Platelet plug formations. কি হবে? Adhesions, platelet to non-platelet surface, activations, then the conformational changes of the 2b3a, 2b3a connected to the von Willebrand factor or fibrinogen connected to others, that means একে অপরের সঙ্গে লাগছে, and the surface area is increasing by the formation of the platelet philopodia, এটাকে বলে philopodia, FILOPODIA, philopodia is formed like that, এরকম করে philopodia is gained. So it means surface area of the plate is increasing, and this increasing surface area is helping for the platelet plug formation. This is a primary hemostasis. But if it is a major bleeding, then coagulation cascade must be there. Coagulation cascade must be there means 3 pathways are there, fibrin formation will be there in the stable form. Now the question is, the next class will be there, that if it is continuously happening in formation of fibrin and fibrin stands, then this means thrombus may cause damage in other organs. After the repair of this, he has to dissolve this way. এটাকে ডিসলভ করতে হবে। ডিসলভ করতে গেলে কি করতে হবে? ফিব্রিনকে ভাঙতে হবে। কে ভাঙবে, কিভাবে ভাঙবে, I will discuss in the next class. Thank you very much. This is my class.
You perform yesterday? Test first? Bicep. So up to in urine, abnormal urine constituents, you have to perform, I think, 4 constituents. The first one is reducing sugar, second one is protein, third one is ketone bodies, and the fourth one is bile salt. Okay? You already know why it is called to be abnormal urine sample, because there is a presence of abnormal constituents in the sample, which are generally not present in our normal urine sample. How can we differentiate normal urine sample, abnormal urine sample? Anybody else? From the last one? Abnormal constituent, just a minute. T-shirt. Yes. You have to the knowledge of other students that they are sleep. But why are you not giving the answer of these questions? You already had so many classes. What is the basic difference between abnormal constituent of urine and abnormal constituents of urine?
Abnormal has one salt present of reducing sugar.
Normally it is not present. Which one is normal constituents? Which one is normal constituents?
Urea, uric acid,
Urea, uric acid, creatinine, urobilin. So all these are what? Normal constituents. And we can divide it down to constituents in 2 types: organic constituents and inorganic constituents. In the inorganic constituent, there is a presence of calcium, sulfate, phosphates. Okay. It is not generally present in a normal sample. Okay. So in some pathogenic conditions, they may be appear and we can identify the presence or check the presence. Okay. Now today we are going to discuss the 5th constituent of abnormal, that is bile pigment. Bile pigment. You know what is the meaning of bile pigment? What is bile salt? What is bile salt? You already completed this practical before. What is bile salt? Bile salt, what is the function of bile salt?
help in fat digestion.
Very good. That's process we call emulsification. Okay. Anybody else? There's so many functions. Okay. Increase the surface area. There is so many functions of bile salts. Helpful in lipid digestion and transports. Helpful in drug metabolism. Xenobiotics, detoxification. Okay. And many more functions. Bile salts. How it is formed? How it is formed? The example of bile salts you already know: sodium glycolate, sodium chloride, or potassium glycolate and potassium perchlorate. Okay. Actually, glycine and taurines are the amino acids. Okay. So when your cholesterol synthesis is occurring in your body, when the cholesterol is synthesized, there is one thing, students. There is a one thing. The first thing is synthesis. Second thing is degradation. Means one thing is synthesized, how it is utilized in the body, it is called degradation. Cholesterol is synthesized, okay, there is cholesterol is formed, and these cholesterol is utilized by three basic performances. For the utilization of synthesis of vitamin D, for the synthesis of bile salt, and for the synthesis of steroid hormone. Okay, so generally these bile salts are formed by the cholesterol bodies. Okay, and what is the function of bile salts? It can reduces the surface tension. Okay, if it reduces the surface tension, there is a more space to act the enzyme. Your enzyme topic is over? In the class, enzyme topic is over?
Yes.
Huh?
Yes.
Okay, so what is the activity of enzymes? It can process other lipolysis. There is change the fat molecule in fat droplets. So how this increase area surface area increases? By the activity of bile salts. Okay, so this property, due to this property, reduces the surface tension, of the solutions. They give positive result. This is the basic principle of Hayes sulfur test. Hayes sulfur test. Okay. Now we talk about bile pigment. Bile pigment is what? Bile pigment is bilirubin and biliverdin. Now you will there is question arising in your mind how this bilirubin is found.
Breakdown of
Very good. Breakdown of heme. So there is some metabolic pathway we discuss later in detail. Okay, but you have to know that you already know the hemoglobin, that is the conjugated protein which is formed by the heme plus globin. How it is formed? By heme plus globin. It is called hemoglobin. What is the function of hemoglobin? What is the main function?
carrying oxygen.
Very good. Carrying oxygen and circulate to the all tissues of the body. This is the basic function. But here after 120 days, these can break down in the graveyard of the bodies. Which one is graveyard?
Spleen.
Very good. Spleen. So this is breakdown. The first one, the RBC become breakdown into first heme and globin. This is further breakdown and produces what? Chain of amino acids. And this is further go breakdown and it produces not iron, directly it produces bilirubin. Iron and porphyrin. So I directly write here bilirubin and it is go for several other processes like conjugation, deconjugation, and it produces finally bilirubin. Bilirubin is not generally present in the urine. Okay. So for the identification of these bilirubin, we perform Fauchet test. Which one? Fauchet's test. Okay. So student, kept in your mind, bilirubin is not generally present in the urine. So that means in some clinical condition that comes in the urine. Which type of clinical condition? Which type of condition? No. We can divide the jaundice in main three types on the basis of our hepatic condition. Pre-hepatic, the hemolytic jaundice is pre-hepatic jaundice. Post-hepatic, that is obstructive jaundice. Hepatic jaundice is there is no conjugation occur. So the bilirubin level is increases. So when this bilirubin is in post-hepatic jaundice condition, there is an obstruction. There is obstruction that it is not, this bilirubin is not enter in duct. Okay. So the bilirubin level increase in post-hepatic condition. And during this condition, these are excreted out in the urine. Okay. Generally, the color of bilirubin is what? Red color. But it is oxidized. Normally, what happens? Normally, these bilirubin is excreted in the urine in the form of urobilinogen. Urobilinogen. That's why the color of the urine is straw color, yellow color, due to the presence of this urochrome. Okay? And these bilirubin, some amount is excreted in the feces in the form of stratobilinogen. Stratobilinogen. Okay? But during post-hepatic condition, during obstruction, these bilirubin directly excrete out in the urine. Excrete in the urine, and for the identification of this bilirubin in the urine, we perform Faucet test. So now make test for bile pigment. Begin heading test for bile pigment. Test for bile pigment. So which test we perform? What is the name of the test? Faucet test. Make heading Faucet test. Fouchet. Fouchet. Faucet test. Faucet test. Okay, write down the principle first. Principle. Bile pigment in urine sample. Bile pigment in urine sample react with barium chloride. React with barium chloride in urine. React with barium chloride to form white precipitate. To form white precipitate. To form white precipitate. So what is the principle? Bile pigment in urine sample react with barium chloride to form white precipitate. Okay? Full stop. आगे लिखिएगा when this dried when this dried when this dried and reacted with Faucet's reagent dried and reacted with Faucet's Faucet's reagent gives green to green to bluish color, green to bluish color, ब्रैकेट में लिखिएगा पिस्ता कलर, Have you seen the color of pista? Dry fruit pista जो होता है ना, bluish color precipitated is obtained. Bluish color precipitated is obtained due to the formation of complex derivatives. Due to the formation of complex derivative. Due to the formation of complex derivative. Okay. Due to the formation of complex derivative. Now, write the procedure, make the adding procedure, make 3 columns and give their heading experiment, observation and inference. Make 3 columns. Experiment, observation and inference. लिखिए एक्सपेरिमेंट में टेक 3 ml of urine sample, take 3 ml of urine sample in a test tube. Then add 2 ml of 10% barium chloride. Barium chloride.
So what happens then add?
Then add 2 ml of 10% barium chloride until white precipitate is observed. क्या लिखा आपका? कोई क्वेश्चन बोलो। ऑब्जर्व, इसमें आगे लिखिएगा फिल्टर इट filter it and add few drops of saturated sorry इसमें लिखिएगा filter it and add few drops of Faucet reagent few drops of Faucet reagent. Few drops of Faucet reagent. Observation में वही लिखिए जो बताया था, क्या नाम? Green to bluish, याद लिख लीजिए डायरेक्ट. Color changes from yellow to green bluish color. Pista color. Color changes from yellow to green bluish color. Color observation. color changes from green to yellow.
सर
Yes.
वाइट प्रेसिपिटेट आया था ना पहले
हाँ
तो येलो से तो वाइट से मतलब
हाँ white से convert होगा.
White से?
Actually white precipitate आ गया. इसका प्रोसीजर ये है, आपका white रेडियम क्लोराइड आपने ऐड किया, प्रेसिपिटेट आया आपका, प्रेसिपिटेट को आपने फिल्टर पेपर में फिल्ट्रेट किया. ठीक है, फिल्ट्रेट करने के बाद जैसे ही आप उस फिल्टर पेपर पे जैसे ऐड करेंगे तो जो ग्रीन कलर उसके साथ ऑब्जर्व होगा इसके साथ, वो ग्रीन कलर जो येलो कलर ग्रीन कलर में कन्वर्ट होगा.
सर वो येलो आया था मतलब पहले वाइट था
उसमें जब आप फिल्टर करेंगे ना तो फिल्टर के साथ में थोड़ा सा यूरिन सैंपल का जो कलर होता है वो ऑब्जर्व आता है फिल्टर में. ठीक, तो वो चेंजेस होगा येलो टू ग्रीनिश ब्लूइश कलर. पिस्ता कलर
greenish, bluish or green to bluish.
बहुत कर लीजिए. आप एक काम करिए, पिस्ता कलर कर दीजिए. ठीक है, उसको आप पिस्ता कलर लिखिए. छोड़िए पिस्ता कलर. फाइनली यू विल गेट पिस्ता कलर. ओके,
Yellow to pista color.
हाँ येलो
तो ग्रीन ब्लूइश कलर दोनों लिख लें.
एक काम करिए, इसे पूरा काट दीजिए. काट दो, काट दो. ऑब्जर्वेशन काट दो. काट दिया. हाँ, अब इसमें देखिए कलर चेंजेस, कलर चेंजेस, कलर चेंजेस फ्रॉम येलो टू पिस्ता ग्रीन. कलर चेंजेस फ्रॉम येलो टू पिस्ता ग्रीन. कलर चेंजेस फ्रॉम येलो टू पिस्ता ग्रीन. इन फ्रेज में लिखिए while pigment alpha, while pigment present. So name while pigment. Bilirubin or इसका इंटरप्रिटेशन लिखना. लास्ट में इंटरप्रिटेशन, इंटरप्रिटेशन, इंटरप्रिटेशन. इंटरप्रिटेशन मैडम पीछे क्या देख रहे हैं?
Sir, inference.
इन्फ्रेंस.
White
इन्फ्रेंस
pigment present. उसके बाद sir bilirubin and bilirubin.
हाँ दोनों. ठीक है, नॉन लिखो कोई बात नहीं. अभी इंटरप्रिटेशन बताओ. यू टेल इंटरप्रिटेशन.
This is abnormal unique with presence of high.
इंटरप्रिटेशन
So ये टेस्ट देख के मुझे क्या पता चला?
clinical significance. Why you suggest the patient to do this test? What the analysis?
To confirm is it jaundice or not?
Yes. To confirm it is jaundice or not. So interpretation is what? It is present. It is positive in all kind of jaundice. It is present in all kind of jaundice. All of you understand what I say? Okay. What the meaning of clinical interpretation means? What the need of this test? Okay. Why the if this test is positive, what is the interpretation? What kind of disease, in which kind of disorder this test is positive test? Okay. Generally in all kind of jaundice. Okay. Now write down another test. Test for blood. Test for blood. Test for blood. Next test. Why are you surprised? If I will say test for blood, you all are surprised.
No sir, there is a change of topic. Taste of urine or other taste of blood.
Test of blood means blood is present in the urine. What is urine? We are talking about generally the whole when having abnormal constituents of urine. So test of blood means if the blood is present in the urine, this test we perform. Okay? But generally we are not performing this test because this is banned. Restricted because banned. Benzidine because it is carcinogen. Okay, so that's why we not performing this test in the lab. But for the knowledge, because this is asking your Y1, this test we perform for identification of blood in the urine and the condition called hematuria. Okay, for hematuria we perform this test, benzidine test. So write down directly procedure. प्रिंसिपल इसका मैं लिखा दूंगा बाद में एक्सपेरिमेंट वही प्रोसीजर लिखिए एक्सपेरिमेंट ऑब्जर्वेशन और इन्फ्लुएंस तीन हेडिंग बनाइएगा इसमें लिखिए राइट डाउन फास्ट a pinch of Benjamin powder, then add 2 ml of glacial acetic acid.
It's a benzamine.
Benjamin. Sorry. Benzamine powder, Benzidine powder. Benzidine powder. Then add 2 ml of glacial acetic acid.
So a pinch of benzidine powder is first.
Then add.
What benzidine powder?
क्या हुआ प्रॉब्लम क्या है
शुरू से
बताओ Benjamin test a pinch of benzidine powder okay add then add 2 ml of glacial acetic acid.
So 2% या 2 ml?
2 ml. Why did we percent? Acetic acid in solid form or liquid form?
Liquid form.
We are not talking in percent. We are taking 2 ml directly. लिखा इसमें कितना लिखा आपने बेंजीन pinch of benzene powder then add 2 ml of glycerin acetic acid add 2 ml of hydrogen peroxide H2O2 अभी पूरा लिख लीजिए फिर समझ में आ जाएगा काम करिए पूरा जो प्रोसीजर है प्रोसीजर डाल दीजिए तो इंट्रोडक्शन लिखिए क्योंकि ये टेस्ट हम परफॉर्म तो करने नहीं है हाँ इसमें देखिए आप सीधा टेस्ट फॉर ब्लड बेंजीन टेस्ट लिख लीजिएगा ठीक है अब इसमें लिखिएगा when blood is present in the urine हाँ प्रिंसिपल नहीं है जनरल इंट्रोडक्शन है एक मतलब एक पैराग्राफ है इसमें when blood is present in the urine it is called hematuria It is called hematuria and is commonly seen due to some injury or disease of kidney
The disease of
or the urinary tract Okay, इसमें आगे लिखिएगा हीमोग्लोबिनुरिया on the other hand refers to the presence of hemoglobin in the urine. It occurs in condition where there is increased hemolysis. इसी में आगे लिखिएगा Benjamin test is done to detect minimal hematuria. Which may not be seen with the naked eye. Care should be taken while handling Benjamin reagent.
So while handling
Benjamin reagent. As it is potentially carcinogenic. A blue or green color indicates a positive test. A blue or green color indicates a positive test. Since benzoline is a carcinogenic compound, it is not done. Analysis is over. In the next time you perform this test for bile pigment. Okay? Now we will revise all the topic of urine analysis one by one, and you will give the answer of all the questions which I will ask you. Okay? urine sample, hey, बात मत करो. Physical examination. Physical examination. The first condition is polyuria. First condition is polyuria. Madam, you. Why it is called polyuria? What is the meaning of that? No, sit down. I clearly say, madam. Yes, you. किधर बैठी? पीछे दिख रही है? पीछे कौन सी लड़की बैठी है?
Excessive urine.
Stand up and tell the volume.
Excessive urine.
Excessive urine. हाँ? क्या पीछे क्या है? कोई फैकल्टी खड़ी है पीछे? बारह पीछे दिख रही, पीछे कभी सर कभी खड़ा कर दो पूरे दिन भर भी है. कितना वॉल्यूम होना चाहिए? Excessive urine means what? What is the normal output of the urine? 1 to
1.5 liter
per 24 hours. Okay. Okay. So in polyuria, how much urination occur? More than? It is called polyuria. Okay? Sit down. Now tell me the condition. Tell me the condition where this polyuria occur. 1.1.
Insipidus.
Diabetes, both insipidus and mellitus. Cause we discuss in next class. Why this occur is there is one clinical symptoms arise in both the condition. This is called frequent urination. Okay. Diabetes mellitus and in the case of insipidus also. Okay. Or any other reason?
Excess fluid intake.
Yes.
Excess fluid intake.
Excess fluid intake. Any other reason? Huh? Diuretics. Take out diuretics. Okay. वो भी मान लिया. और कोई reason? Those who taking alcohol in beer consumptions, in caffeinated diet, caffeinated products, there is symptoms arises called polyuria. We write it here. Alcohol consumption and caffeine, taking of caffeine in the form of tea and coffee. Okay. Now second one is anuria. Anuria. ये totally stoppage of urine or some amount is excreted.
It's less than 0.5.
Very good, very good. Less than 300 ml per day. The third one is oliguria. It is
Less than 1 liter.
yes 800 ml. Reason? What is the reason of anemia?
Sir, acute renal failure. Acute renal failure.
Acute. Acute का तो कुछ है. Polyuria हो. वो हुआ chronic CRF. Chronic renal failure. Okay, totally stoppage होगा. there could be trauma, either in the case of trauma or accidents. There is totally stoppage of the urine. It is called anuria, and oliguria in the case of ARF, acute renal failure, nephrotic syndrome, glomerulonephritis, okay, and some other conditions. So this is the first physical exam called volume. Okay. Now color. Yellow. We talk about abnormal physical examination. Dark yellow. What is the reason of dark yellow? Jaundice. Or other reason? 4-5 years. Red color. Maturity. Hematuria, the reason of hematuria is to be different, like surgical error, surgical implantation error, or any other trauma condition. Red color, and there is red brownish color. Red brownish color. It is the case of hemoglobinuria. Hemoglobinuria. Write it down. See the use mobile.
Sir, I'm not able to see from here, sir.
Okay. Okay, no problem. Black color.
Alkaline.
Alkaptonuria. Okay. Alkaptonuria. Okay, students. So this is the two physical exam, and the reason behind it, we know alkaptonuria, some TTU conditions, phenylketonuria conditions. So these black color is not generally be observed. If we strains urine for some time, so the alkaptones, the crystal which is present, turns black. Okay, that's why the color is appear black, green color is appear. Okay.
Has been done for you. Okay. So, which is the main muscle?
Triceps.
Main muscle touchable.
Triceps.
Triceps muscle is there. Where is the street?
Absent.
उस तरफ जाओ बोलो group B please come here part okay so for knowing that one you know what are the chief muscle in the posterior compartment that is the triceps okay and what any other muscle is there anconeus small part of anconeus any other so this triceps have how many head three. Okay, one is long head, another one is lateral, and another one is medial. So write it down. The main structure in the posterior compartment is triceps. The nerve of this posterior compartment is radial nerve. Okay, and the artery is profunda brachial artery. Okay. Okay, so what are the content? So write it down. Which are the content of the posterior compartment of arm? Number one is the muscle, that is the triceps muscle. Okay, Then nerve, main nerve is the radial nerve, and the main artery, that is the profunda brachii artery. Okay, and another artery is ulnar collateral artery. This is also important. So not only one artery, there is another additional artery that is known as ulnar collateral artery. Now who would be telling me how many branches ulnar artery has got? What artery called? Is profunda brachii artery, another one is ulnar collateral artery. And structure, which are the structure passing through the compartment? Two, one is radial nerve, another one is ulnar nerve. Okay, so ulnar nerve would be starting from here. Okay, radial nerve is a branch of, which branch of brachial plexus? কোন কর্ড থেকে আসছে? posterior cord. ulnar nerve medial cord. ulnar nerve টা আসছে medial cord. Okay. Okay. So see, now the next muscle is triceps. Okay. So origin, if you see the origin, how many it has got? 3 heads. Write it down. First one is the long head. So long head is originating from the last page. So tell me the origin of triceps. There are 3 head. Long head takes origin from the inframenoid tubercle of scapula. Okay. Then the medial head originates from so both are from the humerus, right? Shaft of the humerus. Medial head takes origin from the upper 1.5. Okay, upper half, and the lateral from the lower half. Remember, not the medial or lateral side. Understood? Medial টা হবে upper half এ আর medial টা হবে lower half এ আর lateral টা হবে upper half এ. Okay, lateral টা উপরে থাকবে, medial টা নিচে থাকবে. Okay, so which one is the most deepest? কোনটা সবথেকে deep হবে? Medial head. Okay, so this medial head would be completely covered by the lateral head. Understood? So getting the medial head, you have to take out, in the dissection you will take out the lateral head. Okay. So see, this is the muscle. Okay. So you could see what are the origin. First one is this is the inframenoid tubercle, and this is the lateral half. So lateral head, see, it is coming from the upper half, and the medial one is coming from the lower half, and this is making the tendon. Now tell me where it got inserted. কোথায় গিয়ে insert হবে? Which surface has got how many surface? Olecranon process. কটা? বল কনফিডেন্টলি আনা হয়ে গেছে তো? কটা সারফেস ছিল? Olecranon process এর 5টা. Okay, superior, anterior, posterior, medial and lateral. So these triceps কোথায় দেখতে পাচ্ছি? It will be present on the superior surface of this olecranon process of arm. Okay, you have to mention the superior surface. Okay, you can see what are the nerve supply. Nerve supply is radial nerve. Okay, and what is the action? Extension of the arm at the elbow joint. Okay, so additional, who would be the additional muscle? আর কি করবে? Anconeus করবে, brachioradialis করবে some part. Okay, and you know brachialis. Brachialis is পুরোপুরি flexion করছে তা না, as because it is a deep compartment and it is a hybrid muscle. What is the nerve supply for brachialis? Now বলু, তাই তো? বল, nerve supply for brachialis এর only muscular gluconeogenesis, also radial. Okay, because it is a hybrid muscle, brachialis. Okay, then see, this is the radial nerve. So radial nerve is coming from where? The posterior cord of brachial plexus. Okay, then this is very important, please write it down. Okay, radial nerve कभी-कभी short note आता है, right? So where the radial nerve you could get? How to determine that this is the radial nerve? For that you have to trace the spiral groove. Now the question is, how you will get the spiral groove in humerus? কাকে spiral groove বলে? হিউমেরাস পড়ানো হয়ে গেছে, বল স্পাইরাল রুট কাকে বলে? কোথায় থাকে? অ্যান্টিরিয়র থাকে না পোস্টেরিয়র থাকে? So there is the insertion of deltoid. Have you seen? So that is known as deltoid tuberosity. So now if you press the deltoid tuberosity at the posterior side, there you will get one groove. Okay, there is the lodgement of this radial. Okay, so this posterior part is very much important. So these nerve wings around the back of the arm in the spiral groove. Although it is coming on from the front, but it wings around. Okay, in the spiral groove. Then, so only the radial nerve is going. এখানে একটা কোশ্চেন আছে যে আর্মের একটা নার্ভ সবসময় পেয়ার্ড হয়, ঠিক আছে? নার্ভ would be paired with the artery. Axillary nerve would be paired with very good posterior circumflex humeral artery. Okay, it is found in the surgical niche, both the structure. Okay, so spiral groove you are having two structure, one is radial nerve, another one is profunda brachii artery. So write it down, this may comes as MCQ. Okay, spiral groove not only radial nerve but also profunda brachii artery. Okay, so it lies directly contact with the shaft of the humerus. Okay, it lies direct contact with the shaft of humerus. Okay, so that's why who are having this radial nerve paralysis or wrist drop, কাদের হয় জানিস mainly? Have you seen the who are lumping means that are limb? No, who are have the limb of leg, they used to walk with the scratch. Okay, so they will keep pressure on the this radial nerve. Okay, so there will be a condition called as wrist stroke. Okay, because all the this surface forearm along with the dorsum of hand including the fingertip will be supplied by radial. Okay, so now there is one important course about the radial nerve. What it is happening, it is piercing the lateral facial septum. Okay, so lateral fascia, there are two fascia, one is medial, another one is lateral. So lateral is pierced by the radial nerve. Okay, and above the elbow and then continues downwards in the cubital fossa. So above the elbow it is piercing the lateral facial septum. Okay, then it is going to the cubital fossa. Okay, so how the radial nerve enters to the this forearm? Who will tell me? তিনটে নার্ভ আছে ফোরআর্ম, একটা হচ্ছে মিডিয়ান নার্ভ, একটা হচ্ছে রেডিয়াল নার্ভ, আর একটা হচ্ছে ulnar nerve. Now how the median nerve is coming to the forearm? Between the two head of pronators. So what about this radial nerve? How it is coming? Write it down. It is coming between the brachialis and brachioradialis. Two muscles. Okay, brachialis and brachioradialis. Okay, and there is another thing that is known as ulnar nerve. How it is coming? The two head of flexor carpi ulnars. These three questions are very important. Okay, how this three nerve emerges in the forearm. Okay, so this radial nerve is coming. See, it is already written. Okay, so it is coming between the brachialis and brachioradialis. Remember this one, radial nerve. Okay, so you know this brachialis it is present on the flexor compartment and brachioradialis in the extensor compartment. So how this radial nerve is entering to the forearm? Okay, see, this is the picture. Okay, so see, it came from the posterior cord, radial nerve, then it wings around. Okay, so this is the spiral groove on the posterior surface of humerus. Okay, along with the profunda brachii artery. And see, it is giving the muscular branches. Which are the branches? Tell me. Triceps, all the head. Okay, the lateral head, long head, and the medial head. All are supplied. These are the muscular branch. Okay, then it is coming downwards. And see, on the posterior side there is one nerve that is known as posterior cutaneous nerve of arm. It is a branch of radial. Okay, then rather than that, it is coming in front. Okay, it is supplying the medial fibers of the triceps. Okay, and this is known as deep branch of radial nerve. Then this radial nerve divides into superficial and deep. Okay, so deep would be supplying whom, superficial would be supplying whom. Deep would be supplying the all the muscle present in the forearm. Okay, just like brachioradialis, just like extensor carpi radialis longus. Okay, just like acromius. So what about the superficial branch? It will give the superficial branch का सेटा काके देते हैं? Posterior intraosseous nerve is a branch of radial. Okay, and all the cutaneous nerve of the forearm. এখানে আর কোনো নার্ভই নেই. Okay, so all the cutaneous nerve of the forearm, this posterior side, it would be supplied by radial nerve. It would be the direct branch of radial nerve. Okay. So see, this is the cutaneous variation of the radial nerve. So first one is this one is the lower lateral cutaneous. Write it down. These are the cutaneous branch coming from the radial nerve. Number one, this one is the, see, only this portion would be supplied by lower lateral cutaneous nerve of arm. Okay, just above the elbow on the lateral side. Okay, so first one is lower lateral cutaneous nerve of arm. Then I told you this one, posterior cutaneous nerve of arm. Then posterior cutaneous nerve of forearm, and this is the superficial. So now you could understood. See the dorsum. Okay, dorsum from where? From the thumb up to the 1.5. Okay, 3.5. So this 1.5 is completely supplied by ulnar. Both the dorsum as well as the front on the palmar aspect. Okay. So these are the cutaneous branch directly coming from the radial nerve. Okay. So next one is, what are the branches of the radial nerve? There are 3 different type of branches. কি করে branch হবে? প্রথমে axilla তে what are the branch? Write it down. In the axilla, muscular branch of the long and the medial vein. It is not supplying the lateral vein. Remember, long and the medial vein. Then posterior cutaneous nerve of arm. Write it down. So there is 2 branches. Number 1 is muscular branches of long and medial head of tricep, posterior cutaneous nerve of arm. Okay. Then in the spider group, muscular branches to medial and lateral head of triceps and the acromius. So see this medial head getting the branch twice. Okay. Medial head is very important because it is getting the same branch twice. Okay. Then along with the acromius. Acromius is a very important muscle. Okay, which is chiefly responsible for the supination. Okay. Then next one is lower lateral cutaneous nerve of arm and posterior cutaneous nerve of forearm. It is not the arm. Axilla, it is the arm. But here we are having forearm. Okay, so these are the branches in the spiral group. So ऐसा होता है, means in the dissection, in the OSP, suppose the radial group is marked. So they will ask, tell me which are the different branches found in the spiral group. Okay, of radial nerve. So at that time you have to mention all this. Spiral group is very much important. Okay. The next one is on the anterior compartment of arm. Anterior compartment. Okay. So number 1 is muscular branches to brachialis, brachioradialis, and ECRL, extensor carpi radialis longus. So 3 muscles. It is supplied. Then the articular branch to the elbow joint. I told you in elbow how many branches are there? Articular branches 5. Okay, but in knee joint there is 9 branches. Okay, so remember this. Okay. So one of the branches is also coming from the radial nerve. Okay. Okay, next one is the ulnar nerve. So ulnar nerve is a branch from the medial cord of brachial plexus, and every nerve root value is very much important. Okay, in the brachial plexus as well. So it pierces the medial facial septum. So यहीं से एक MCQ आ गया, lateral facial septum is pierced by radial nerve and medial one is pierced by ulnar nerve. Okay, then it descends behind the septum, covered posteriorly by the medial head of triceps. So how you will get the ulnar nerve? It is very deep. Okay, very deep in the arm. You have to take out the long head, then the lateral head, then the medial head, then you will get the ulnar nerve. Okay, and this nerve is accompanied by superior ulnar collateral vessels. So I told everything is paired. Oh, so this one is the superior ulnar collateral vessels. Okay, it is going along with the ulnar nerve. So see, this is the ulnar nerve. So how it is coming? What is this? This is the medial epicondyle. Okay, so that's why it is known as the funny bone. Okay, so it is coming from the posterior side. Then it is going over here. There is two head of flexor carpi ulnaris. Okay, how many heads? Origin. Which are the origin? Flexor carpi ulnaris. Which are the two origin? It is already taught to you. বল কি কি দুটোই কি আলাদা করে নেবে একটা common flexor origin, okay, and another one it would be definitely from the ulna. Okay, so where ulna already পড়ানো হয়ে গেছে. So this is the ulna, right? This is the radius, this is the ulna. So where you are seeing, this is the coronoid process. Okay, anterior. So see, next one is at the elbow it lies behind the medial epicondyle. So remember this relation, it will be always lying behind the medial epicondyle. Okay, and it continues downwards to enter the forearm between the two head of flexor carpi ulnaris. So the ulnar nerve also giving articular branch to the elbow. তাহলে কি কি নার্ভ দেবে এলবোকে? medial nerve দেবে, ulnar nerve দেবে, then radial nerve দেবে, any other nerve for the result. Okay, so this is the ulnar nerve having the articular branch to the elbow joint. Okay, so see, this is the ulnar nerve. How it is coming? It's a branch of medial cord. So where it is entering? It is piercing the medial facial septum and it would be found the medial head of triceps. Okay, then it is coming to the medial epicondyle and see, this is the two head of flexor carpi ulnaris and then it is entering over here and these are the branch going to the finger. Okay, hold the little finger along with the half of the ring finger. Okay, so what are the branches it is giving? Who will tell me in the forearm? ulnar nerve এর কোনো ব্রাঞ্চ আছে আর্মে? নো. মিডিয়াল নার্ভের আছে? রেডিয়াল নার্ভের আছে? আর কোন নার্ভ আছে? মাসকুলোকিউটারিয়াস. মাসকুলোকিউটারিয়াস শুধু আর্মকে নিয়ে শেষ, ঠিক আছে? তারপরে আর কোনো ব্রাঞ্চ নেই. সো এটা কি ব্রাঞ্চ আছে ফোরামে? What? Flexor digitorum profundus and his fourth muscle flexor carpi ulnaris. ঠিক আছে, ওর দুটো পার্টের মধ্যে যাচ্ছে ডেফিনেটলি সাপ্লাই হবে 1.5 muscle. Okay, in the forearm. Then it is become the cubitus. So next one is very important, profunda brachii artery. Okay, so it's a brachial artery runs on the anterior compartment, but profunda brachii artery on the posterior compartment. Okay, but we are seeing in the lower limb, if you compare the femoral and profunda femoris artery, where you will get femoral artery and profunda femoral artery, right? Arteria profunda femoris কোথায় থাকে? লোয়ার লিমে. Yeah?
Femoral nerve and femoral artery runs to
So it will be found in which compartment?
anterior.
Where you will get? কোন জায়গা থেকে বলবি এটা প্রকাণ্ড ফেমিনিস আর্টারি? ওয়ার্ড তো বলা হয় না, রাইট? ওর একটা ব্রাঞ্চ কোন জায়গা থেকে বলবি? Deep osteoapneuritic opening of adductor magnus. Okay, deep osteoapneuritic opening of the adductor magnus, যেটাকে আমরা বলছি adductor canal. তারপরের পার্টটাকে আমরা বলবো প্রকাণ্ড ফেমিনিস আর্টারি. Okay, so it accompanies the radial nerve in the spiral groove, supplies the triceps and takes part in the anastomosis in the elbow joint. Okay, so it is supplying triceps muscle definitely. Okay, another anastomosis along with the elbow joint. So these are the two supply of the profunda brachii artery. Okay, then how many branches it has got? Superior and inferior ulnar collateral artery. Okay, superior and inferior ulnar collateral artery. So what is the branch of brachial artery? এটা তো গেল প্রফান্ডা ব্রেকিয়াল আর্টারি, ঠিক আছে? তাহলে অ্যান্টেরিয়রলি হচ্ছে ব্রেকিয়াল আর্টারি কি কি ব্রাঞ্চ আছে? রেডিয়াল আর আলনার আর্টারি। রেডিয়াল আর্টারি কটা ব্রাঞ্চ? একটাই, আমি বলছিলাম রেকারেন্ট ভুলে গেছে আবার সাপ্লাই দিচ্ছে, সো রেডিয়াল রেকারেন্ট আর্টারি। আলনার আর্টারি কটা ব্রাঞ্চ? একটা হবে আলনার কোলাটেরাল আর্টারি, আর দুটো কি কি? এটা তো is branch. Superior and inferior collateral artery is a branch of profunda brachial artery, not the brachial artery. বুঝতে পারলি? profunda brachial artery is running on the posterior compartment, but brachial artery is running on the anterior compartment. So anterior compartment এ যেটা ulnar artery দিল সেটা কি কি ব্রাঞ্চ আছে? একটা হলো recurrent ulnar artery, আর দুটো কি? anterior introosseous আর posterior introosseous, ঠিক আছে?
profunda brachii artery তো লেটারাল একটা anterior descending branch করে আর একটা posterior descending branch করে, আর superior আর inferior আমরা তো brachial artery থেকে medial introosseous করতে আসছে।
না না, এই দুটোই হচ্ছে মেইন ব্রাঞ্চ। ওকে, মেইন ব্রাঞ্চ অফ profunda brachial artery is superior and inferior collateral ulnar artery. Okay, which will supply the elbow joint. Usually, and what you are talking about, that is the anastomosis in the elbow. Anastomosis of the elbow joint. I told you 5 arteries. Okay, that will be supplying the elbow joint. Okay, so these branch superior and inferior ulnar collateral artery arises from brachial artery and take part in the anastomosis of elbow joint. Okay, then see, this is the course, how it is running. So at first you are having this one. This is the arteria profunda brachial. Okay, so what about this one? This main artery is the brachial artery. This is the thickened one. Okay, so see, this is the anastomosis. So there is anterior ulnar recurrent, posterior ulnar recurrent, okay, radial recurrent. Already 3 you got, and this superior and inferior ulnar collateral. 5 arteries. Radial একটা আছে না, 4টে ulnar আছে. Okay, so that is supplying this elbow joint because it is very much important. Okay, so after knee joint, next joint is elbow joint. Okay, so which one is the most unstable joint in our body? Shoulder. Always remember, এটা MCQ আছে, unstable joint বললে shoulder joint. তুমি যদি বলে most movable, again it is shoulder joint. Unstable body is move করতে পারবে না। Okay, so see, this is the arterial branches. Okay, this picture became blurred. Okay, so now you see the structure in the